in another way. So with that, are we live? Good afternoon and welcome to the Health and Government Operations Committee hearing. I am Vice Chair Bonnie Cullison. My esteemed and wonderful chair, who sends her greetings to everyone, is currently over in the Economic Matters Committee providing testimony on a bill that she has before them. She will be coming back to join us as soon as she can. Just a few reminders for the listening public and those who are here in the committee. Technology can be glitchy. We're asking for your indulgence and patience if we encounter any of those glitches. Please silence your cell phones. Put them on vibrate or off. There's no food or drink allowed in the gallery just because we have to clean it up if it's there, so makes it easier for us if there's none allowed. This is how we roll with each bill. We will first hear from the sponsor and the sponsor's panel, and then we will follow that with all person witnesses. Usually we go in the order of favorable, favorable with amendments, and unfavorable, and then all virtual witnesses in that same order. However, we will change that if there are large numbers of witnesses. We will alternate between favorable and unfavorable to make sure there's an equal opportunity to make all the points. The bill sponsor is not timed in their testimony, but we ask them to be reasonable and fair in using their time. Every other witness is allotted 2 minutes to provide testimony, and there's a timer on the screen, and there's also on the desk a little set of lights. The green light means you've still got most of your 2 minutes left. The yellow light means you better start wrapping up, and the red light means please finish up your testimony. Please adhere, I'm going to ask the committee to adhere to our usual rules of 1 question and 1 answer. Particularly today, we have a lot of people who have come to talk to us today, and we want to make sure that they have a chance to be heard. Members of the public are able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. Today, we will hear the bills right now in this order, but please be understanding if we have to be flexible based on when a sponsor is available or something changes our time. But right now the order is House Bill 745, 830, 820, 659, 576, 848, 995 and 869. With that, I'm going to call Delegate Guyton to the table with your panel. Delegate, please.
Thank you, Madam Chair.
This is State Board of Professional Counselors and Therapists, Behavior Analysts, Licensure Applications. And
thank you so much, Madam Chair. Thank you to my wonderful friends on HGO. For the record, I am Delegate Michelle Guyton, Baltimore County District 42B, and I bring to you for consideration today House Bill 745, which simply helps improve access to what's considered the most effective therapy for kids with autism. So one of the most beneficial therapies that we know of for children with autism is called applied behavioral analysis. If you want to know more about that offline, I'll be happy to give you a tutorial, but in the interest of time, you'll have to trust me on that it's a thing and that it works. Right? There are many families who remain on the waiting list for these services because they're not available to them, right? And there's something that we can do about that, because the turnaround time for licensing here in the state of Maryland is extremely long compared to the states around us. And that is what this bill is trying to fix. The sooner licenses can be approved, the sooner that children with autism can begin treatment, and you all on HGO know early intervention is key to the best outcomes. So House Bill 745 establishes a timeline for the issuance of a license to practice ABA to a qualified applicant. And this bill requires that the State Board of Professional Counselors and Therapists issue a license within 10 days of receiving all the completed application. And it requires the State Board to provide email notification regarding the status of that application for the license. So I respectfully request a favorable report on a really simple bill with no cost that really could increase access to needed therapies for our kids. Thank you.
Thank you, Delegate. Who would like to go next?
Madam Chair, I will go next. My name is Dan Shattuck. I'm here today on behalf of ACORN, a provider of ABA services here in the state of Maryland. I think the delegate did a great job introducing the bill and what we're trying to achieve. The turnaround time for licensure is abnormally long. There is a tremendous wait for these services, and what we're trying to get is really two things with this bill. A set time frame under which the board has to operate, but also some transparency and the ability for the applicant to reach out and inquire where their application is in the status. The application process now is paper-based, and we're not asking to change that, but as we look at how fast things are being processed, I think giving a deadline is going to be essential, and allowing the applicant to inquire or have a designated third party be able to inquire if it's a credentialing office or something like that. So we think it's a straightforward bill. We appreciate your consideration, and we have some experts here to tell you a little bit more. Thank you.
Go ahead.
Hello, my name is Carrie Victorio, and I am a BCBA currently working as a clinical director at Acorn Health, managing our Germantown and Silver Spring locations. I've been in the field of ABA since 2011, and I've been a BCBA since 2018. I most recently was licensed as a behavior analyst in the state of Maryland in December 2023 when I relocated from Southern California. At that time, I knew my employment was going to be contingent on state licensure, so I sought that in both Maryland and Virginia. While Virginia processed my application within 10 days, Maryland took nearly 6 weeks to do the same, which, as you might imagine, was incredibly stressful when I'm trying to accept jobs in another state and figure out my relocation timeline. These cumbersome wait times not only impact people coming in from out of state that are seeking licensure, but they impact new clinicians who have just passed their exam and are fully approved by our board to practice, but cannot begin to credential with insurance companies until they receive that licensure, so cannot start helping children with that credential until they are licensed. Most recently, one of our new BCBAs at Acorn waited 75 days for her licensure to be processed. So that was months and months of time before she could be client-facing and help the clients that we serve. Becoming a BCBA requires a massive commitment of time, education, and money from our practitioners. And so retaining them is challenging in an already understaffed field when they pass their exam. These licensing delays add to that challenge and not only prolong the time before they can take on a caseload, but prolong the time before they can help clients. Applied behavior analysis is a medically necessary service that provides greater freedom and independence to our clients on the autism spectrum by teaching skills across the developmental domains of socialization, communication, and adaptive skills. And we also work on reducing harmful and dangerous behaviors that are limiting to these clients across different community settings. It's crucial that we get children recommended for these services into care as early and efficiently as possible to maximize progress and impact. Every second truly does count. We have nearly 1,000 children on our wait list in Maryland. So this is something that we can do right now by shortening licensing times to help those kids get access to care. Thank you.
Thank you for your testimony. Who's next, please?
Madam Chair, Barbara Brocato here in support of, and I have to look, House Bill 745, and on behalf of Acorn, and I want to say me too.
Thank you. And by the way, the committee loves it when you say me too, okay? After it's been stated like 5-10 times. Thank you. Next, please. Is that it? Yeah, Andrea Mansfield? Will you please come up? Okay, it says just favorable, not support with amendment, but go ahead and have a seat. Go ahead.
Okay. Do I come back?
No, hold on. Just come back. You know what, Andrea? We have you here as favorable and part of the panel, so I'm sorry, but it doesn't matter. We'll get to you, okay? So everyone there testify already. We're going to open it up for questions. Are there questions? Delegate Kaiser?
Thank you, Madam Chair. Thank you, Delegate Guyton. I have a two-part question, or I guess maybe an easy question and then maybe slightly harder. You said we were worse than other states, and you used Virginia, but do you have the data? What's the overall average? And if that's not something you can have now, could you get back to us?
I don't have that right here in front of me, but there are states that don't require licensure at all. For instance, California does not require state licensure. So I was practicing there with my board certification, which was issued to me by the BACB, without licensure. So it's not necessary to practice in all states.
Okay, I was just trying to get the licensure numbers. And then my second thing is, I don't think anyone testified in opposition, but there's a letter of information, which is essentially a letter of opposition from the Department of Health. Did you speak with them? They say they would be fine with 30 days. I mean, I guess I want to understand from you and them, you can only talk for you, about that, like going from this to this might be too hard for them practically, but maybe this is the first step, and then we get them to 30 days, and then in a few years you go to 15 days or something. So have you spoken with them?
Thank you for your question, Delegate Kaiser. There are two more witnesses favorable virtually that are going to, is my understanding, they're going to address those two issues. Is that correct? The wait times.
Actually, hold on one second. Can you bring those two witnesses up, please? I believe they're April Bailey and Scott
We only need one of them to do that.
Semmel. Good afternoon, Ms. Bailey. Will you be so kind if you could hear me and unmute you can go ahead and start your testimony.
Hi, good afternoon. I appreciate you taking the time to listen to me on House Bill 745. My name is April Bailey. I am a part of the payer team with Acorn Health. So the delay in processing licensure for healthcare providers, especially for those offering applied behavior analysis, we know that it's a significant barrier to accessing timely and effective care for patients with autism. For individuals with autism, science has proven that early intervention is crucial. So the sooner a child ABA therapy, the better their chances are for improved, social communication and adaptive skills. However, whenever the licensure delays occur, which happens every time somebody submits an application for licensure, the therapists who are already qualified are not able to provide that therapy at that critical early stages of development. And it sometimes can make the wait list longer for our families or force them to seek services outside of their preferred provider, even when we have spots available to take those individuals. ABA is essential for child's progress and independence. We already know this. And so if the therapists are waiting months to the proper licensure, it can often mean that the difference between timely intervention and a loss of opportunity growth for that child. So ultimately, the delay in processing licensure, it's not just an administrative inconvenience. It's a barrier for those families to access their medically necessary treatment for autism. Thank you.
Thank you. Mr. Scott Semmel, will you be so kind and give us your testimony?
Sure. Thank you so much for
Thank you.
allowing me to testify today. My name is Scott Semmel. I'm the VP of Payer and Government Affairs for Acorn Health. I'd like to just echo my sentiments of Delegate Guyton and my colleagues, but also answer your question. I understand there may be limitations in the ability to shrink the time frame immediately, and we would be more than happy to entertain a discussion in terms of what that improvement plan would look like. Most of the states that we operate in, the timeline is from 14 to 30 days for that licensure to be completed and validated. So that would be ideal in addressing, the swift and immediate needs of these patients. Thank you.
Thank you. All right, are there questions for any of these witnesses? Delegate Kaiser, do you have a follow-up?
No, just to thank Mr. Semmel for answering my questions.
My pleasure.
Thank you.
You're welcome. I had a list here, and I had Olston and Collison. She asked a question, how you like that? Next time, I'm going to take all the witnesses, and then they'll be like, we answer all the questions. Oh, Delegate Gazzoni. Go ahead.
Thank you, Madam Chair.
My pleasure.
There were a lot of letters getting thrown around, so I wanted to check to make sure I was understanding all of them as kind of my first question. I'm going to have a follow-up. So BACB?
That's our board, the Board of Behavior Analysts. That's who licensed, that's our licensing board as board certified behavior analysts. So it's the Board of Applied Behavior Analysis.
Okay.
Yeah.
Okay. And I'm also, my bigger question, because there was alphabet soup, but I mostly followed it. And I worked at NASA for years, so I'm not unused to alphabet soup. I think it was mentioned that right now this is a paper-based process, which seems to be a challenging thing here in the 21st century.
Yes.
So I'm curious about that and how much impact there may be based on that it's a paper-based product.
Right.
Process, so.
Well, I think you're asking a great question. A lot of the boards, have been transitioning from paper-based to electronic-based, not wanting to create a fiscal note. We're trying to establish, within the processes that exist, if there's a way to expedite, or not, I don't want to create an expedited license, but if there's a way to approve and review in a more timely way, because from our communications with the board early on to get a better understanding of their licensure process, we were told that upon receipt of an application, it wouldn't be reviewed until the paper check was cashed, and then once that check was cashed, the review would begin. So that time lag between receiving the check, receiving the application, meanwhile, the applicant not knowing the status of that process and where things are, contributes to the delays. So if there's a way to kind of improve the flow of, the review of the application even, like, do you need to wait for the paper check to cash or to clear? And then on the back end, once, let's say the application's been reviewed and approved, then the license won't be issued until the licensure fee is paid and that is cleared. So there's another, bank delay, if you will, on finalizing everything. So there's a lot of moving parts that aren't necessarily transparent. The applicant isn't aware. The third party that's trying to hire them isn't aware. So we're trying to bring some of that into the law, just having a timeline, something to work for, and then providing notification.
Thank you for that information.
Sure.
And I beg your pardon, it's the Behavior Analyst Certification Board. It took me a moment.
Thanks.
Thank you. So I have Delegate Johnson, followed by Bandari.
Thank you, Madam Chair, and
You're
thank you,
welcome.
Delegate, for bringing this bill. I'm reading the Maryland Department of Health letter of information, and they say that a lot of the delays are due to folks not submitting all the information needed, and that would make the 10-day window very difficult. The board believes the extended this window to 30 days would be reasonable. But doesn't the bill address that on page 2, number 3, where it says if they don't submit all the information, the board shall issue the license within 30 days after receiving the additional information?
Absolutely, Delegate. Thank you so much for that question, and you are correct. This does not apply to applicants who have not completed the application. This applies to completed applications, and then you do have extra time if they don't.
Okay,
Yes.
go ahead.
And is 10
Oh,
days?
I apologize.
Is 10 days reasonable if they have all the information they need?
Yeah, my understanding is yes, and I think other boards have a policy if there is a completed application and everything is in order, then they can get it all, wrapped up within a 10-day window.
All right, thank you. Thank you, Madam Chair.
So we just recently passed House Bill 256 this morning on the floor. It was on third reader. And House Bill 256 dealt with this board and initially they wanted the sunset to be 5 years, but the committee discussed the matter because of all the issues. We only allowed it for 2 years. So it will be a little bit difficult, given all the issues that we know, that we learned in committee, for them to be able to do it in 10 days. But I do want to make you aware, and that being said, you know, I'm not saying what will happen with the bill, but I thought you should know that House Bill 256 was voted on the floor. We all voted for it today, that actually does the extension only for 2 years because of the issues. We did not give them the 5 years. Okay? Any other questions? Thank you so much, and thank you all for your testimony. And Delegate, thank you for your work.
Thank you, Madam Chair.
My pleasure. All right, so next we have, I think this is it for this bill. Andrea Mansfield. Oh, that's right, thank you. Andrea, we just want to leave you out, period. We have it against you today. I don't know what it is.
It's been one of those days. It's okay.
Tell us about it.
Thank you, Madam Chair, members of the committee. Andrea Mansfield. I'm here representing the licensed clinical professional counselors. And actually, the counselors fully support the intent of this bill, and they like the establishment of the timeframes as well as the improved communication, but they are concerned that the 10-day timeframe would be too short for the board to go through and review all of the information, just to ensure that there's sufficient sign-off by a supervisor, and that they can verify the details and ensure the compliance with all the procedures. I mean, the behavioral analyst is just one of many types of licenses that this board issues and oversees. There are professional counselors, alcohol and drug counselors, marriage and family therapists, professional art therapists, as well as the behavioral analyst. So they're trying to juggle and monitor, or kind of, I guess, manage their time accordingly based on the volume coming in. So for that reason, just to give the board that flexibility, I know if they have more applications in one area than another, they would want them to have the ability to kind of balance that workload for them. So therefore, my client is supporting this bill with amendments to make it a 30-day time frame. They feel comfortable that the 30-day would provide sufficient time. I guess I would add, too, I know that there was a backlog of licenses. I think many of the professions that this board licensed were not happy about that. My understanding is that they have been really working hard to try to address that backlog, and they almost fully have. And I was also going to mention, Madam Chair, I know that the bill dealing with the sunset review that was amended to put the board in place for another 2 years to review some of the other issues, as they had to have some staffing issues and things in the more recent years or so. With them, we support the bill with amendments to amend that time frame to 30 days versus the 10 days. Thank you.
Yeah, and thank you for your testimony. As you know, the committee is very aware of the issues, which is why we didn't grant the 5 years. We did it for 2 years, so they have to come back. I like you, if you can meet with the sponsor when we're done,
Yes.
and see what you guys can work out, okay?
Yep, thank you. Be happy
As
to.
well. Are there any questions? Hold on, any questions? All right, seeing none, thank you so much. Well, this really concludes the bill hearing, okay, on House Bill 745. Is Delegate Jones here? Yes, Delegate Jones, I like how you just pop up, come on. Yes, and after Delegate Jones, we are going to do the House Bill 995 for those witnesses to get ready. And you can bring your panel, please.
Hey. Great, how are you? Delegate Jones. Hi. This is Deborah, and she's our patient advocate. Yeah, kind of stick. There you go.
Good afternoon, you can get started.
Good afternoon. For the record, I'm Delegate Dana Jones, representing District 30A in the House. That is Annapolis and Anne Arundel County. Chair Peña-Melnick, Chair, Vice Chair Collison, and members of the Health and Government Operations Committee, I come before you today to introduce HB 830, Health Insurance, Genetic Testing, and Cancer Imaging, Required Coverage and Prohibited Cost Sharing. This legislation will increase access to recommended testing for inherited gene mutations and evidence-based screenings by eliminating burdensome patient cost-sharing requirements. My panel will address the technical specifics of the testing, but I would like to speak to the fundamental issue and reason I and my co-sponsors are sponsoring this bill: equity. As many of you know, continued advancements in genetic testing provide vital health information to patients, their family, and their medical providers. Genetic testing can also serve as a catalyst for patients to access prevention and treatment strategies. However, significant disparities exist regarding who receives these tests. According to a 2020 report from the American Association for Cancer Research, 65% of young white women with breast cancer were offered genetic testing, whereas only 36% of young Black women with breast cancer were offered the same testing. Additional studies showed that minority patients are more likely to utilize genetic testing following cancer diagnosis, but less likely to do so when there is family history of cancer. This results in missed opportunities for mutation detection and cancer prevention for these patients. As we know, catching cancer early saves lives. This is especially critical for Black women, as they have a 40% higher mortality rate for breast cancer than their white counterparts. Early detection not only saves lives, but it also saves money. According to the World Health Organization, treating cancer patients diagnosed at an early stage is 2 to 4 times less expensive than treating those diagnosed at more advanced stages. In addition to the cost savings from early treatment, eliminating cost sharing for genetic testing of inherited gene mutations will have a minimal impact on premiums. A recent report from the Maryland Health Care Commission indicated this change would increase premiums by 0% to 0.06%. I'm proud to say that this bill has been reviewed and unanimously endorsed by Maryland's Women's Caucus as a priority bill for the 2025 Women's Healthcare Priority List. By eliminating all cost barriers to genetic and evidence-based testing, we will ensure that every woman with a personal or family history of cancer has access to testing. This will save lives, reduce costs, and help reduce disparities in health outcomes among patients. And I would also want to mention we have received some proposed adjustments from the MIA, and I am happy to work with the committee to review these and potentially include them in the bill. Additionally, I would be remiss if I did not give due credit to my co-sponsor, Delegate White Holland, and the work that she has done on this as well, so I'm very appreciative. With that, I respectfully request a favorable report on House Bill 830. Thank you.
You're welcome. Who's next from your panel?
Sure. Hi, Delegate Pena-Melnick and Delegate Collison and members of the HGO Committee. Thank you for the opportunity to speak here today in support of HB 830, which relates to coverage of genetic testing for inherited cancer mutations and the recommended screenings based on the results of that testing. For the record, my name is Angelica Katz, and I am the Regional Manager for State Policy and Advocacy at Susan G. Komen. Komen is the world's leading nonprofit breast cancer organization representing the millions of people who have been diagnosed with breast cancer. And we are advocating today on behalf of the 6,270 individuals in Maryland who will be diagnosed with breast cancer. And ironically enough, the 830 who will die from the disease in 2025 alone. I don't think it's a coincidence that this bill number is HB 830. And as I mentioned, 830 individuals are projected to die in 2025 from breast cancer. Genetic testing can provide important information for breast cancer patients, their family members, and their medical providers. Not only do the results from genetic testing help individuals and their family members understand the inherited risk of breast cancer, but as Delegate Jones had mentioned, it can be a catalyst for patients to access targeted prevention and treatment strategies. We did have a patient advocate who unfortunately was diagnosed with metastatic breast cancer, and she was provided 14 more months to live because of genetic testing. Genetic testing was able to extend her life and was able to provide more hours and time with her family members. We also know that studies have shown an estimated 83% of eligible patients that underwent multi-gene panel testing had made changes to their medical management. So this bill is a prevention tool. It's not just cost savings, but it is prevention and treatment earlier for patients to get in the door and know what their risk is, and to make, okay, and I know my time is up, so I'll just finish there. In support of, I'm sorry, as committed partners in the fight against breast cancer, we urge you to support HB 830. Thank you.
Thank you. Next, please. And thank you for the work you do. We appreciate it.
Thank you. We appreciate the work you do.
Delegate Jocelyn Pena Mielnik. I'm sorry if I
Melnick, yeah, you got it.
mispronounced that.
I know, it's a mouthful.
Delegate
It is.
Bonnie Cullison and members of the Health and Government Operations Committee, thank you for the opportunity to provide testimony in support of HB 0830. My name is Deborah Coleman, and I am a resident of Montgomery County, Maryland. As a two-time cancer survivor, it is essential that I lend my voice in support of this life-saving legislation. My divine mandate is to help others so they prayerfully never receive a cancer diagnosis, or to ensure they have access to the best care if they do. I was diagnosed with early-stage breast cancer in 2012 at the age of 37. In 2020, I was diagnosed with a rare gastrointestinal cancer at the age of 45. By way of background, my maternal grandmother, Cynthia Tate, was diagnosed with breast cancer when she was in her 40s. By the grace of God, she survived her bout with breast cancer and lived cancer-free until just shy of her 95th birthday. Her daughter, my maternal aunt, Lorraine Bragg Tate, was diagnosed with pancreatic cancer, which took her life at the age of 57. My paternal grandfather, Theodore Roosevelt Coleman, was diagnosed with colon cancer when he was in his 80s. Thankfully, he did not succumb to cancer. I do not have a complete family history, but I am aware of 3 other paternal relatives who were diagnosed with cancer. All these third-degree relatives are cousins. One cousin was diagnosed with stage 4 cancer as a young woman. The other 2 cousins are sisters, both of whom were diagnosed with breast cancer in their later years. The elder of the 2 sisters recently completed treatment. Thankfully, all 3 of my cousins are survivors. I don't know if these relatives had access to genetic testing, but I did. I received genetic testing after my breast cancer diagnosis in 2012 and again in 2014, 2016, and 2021. The genetic test in 2012 and 2014 looked for mutations in the BRCA1 and BRCA2 breast cancer genes. No mutation was detected in either instance. The genetic test in 2016 and 2021 looked for mutations in multiple genes. The test in 2021 evaluated 84 genes.
It's okay, you can take your time.
Okay, thank you.
Take your time.
Now you tell me. Okay, so all my genetic test results were considered negative. However, the additional findings for the genetic test in 2016 and 2021 were interpreted as variants of uncertain significance, or VUS, meaning there was insufficient data at the time to determine if the variants in the specific genes analyzed caused an increased risk of cancer. I don't know how many of you have been directly or indirectly impacted by cancer. We can all agree that when faced with this life or death scenario, you want access to all available resources. Regardless of the results, genetic testing represents exactly that, namely access to potentially life-saving information. My genetic testing was critical in providing me with vital information about my genetic makeup. It also provided peace of mind knowing that I did not carry any genetic mutations, despite my family history. I did not have to change my medical care, and for that I am grateful. I know others who were not as fortunate. For anyone with a personal or family history of cancer, genetic testing is critical in determining whether they carry any gene mutations and can help them make the appropriate steps to manage their future health. This bill will ensure that genetic testing is available to all Marylanders as medically necessary. Genetic testing is a way for patients to have access to their genetic makeup and not only take healthcare into their own hands, but also ensure they have the best options available to manage their medical care. For these reasons, I strongly urge you to support HB 0830 and vote to pass this legislation. Thank you for your consideration.
And thank you for sharing your story with us. Okay, I don't want you to think that it does not matter, because it does. And I'm so glad you're here, okay? And I pray that you continue to stay healthy.
Thank you.
You're welcome. I'm going to open it up. Do you have anyone else on your panel? Okay, I would like to open it up for questions now from the committee. Any questions? All right, that means you did an excellent job, okay? Thank you so
very
much.
much. I
You're
appreciate it.
welcome. So we have Patrick Hogan.
Representing Susan G. Komen, ma'am, so just me too.
All right, anyone else? There was someone else on your panel?
Sure.
Yes.
Thank you for the opportunity, Madam Chair. My name is Lisa Schlager, and I'm a constituent as well as the Vice President of Public Policy for an organization called FORCE. FORCE is a national nonprofit that advocates for people with or at risk of hereditary cancers. Most of our constituents carry an inherited genetic mutation that increases their cancer risk. As somebody with a BRCA1 genetic mutation, I am one of them. I'm here as a proponent of HB 830 on behalf of myself and our Maryland constituents. You've obviously heard of the BRCA mutations. They cause up to a 70% risk of breast cancer and a 60% risk of ovarian cancer, as well as higher risk of melanoma, prostate, and pancreatic cancer. However, as you heard, dozens of other genetic mutations have been discovered that increase cancer risk. For instance, Lynch syndrome, people with Lynch syndrome face up to an 80% risk of colon cancer. Included in this bill is the multi-gene panel genetic testing, which identifies people with a genetic predisposition to cancer, which enables personalized, guideline-recommended screening and prevention. This is not ancestry testing. This is medical-grade, highly accurate genetic testing that evaluates for a range of genetic mutations, and it provides cancer risk assessment in a comprehensive way that can inform precision medicine. When the recommended interventions are followed, cancer can be prevented or detected early when it's easier and less expensive to treat. But unfortunately, a lot of the screening services are not included under the ACA. So the entire cost of these, quote, supplemental cancer screenings are often applied to the individual's deductible or not covered at all. This results in thousands of dollars in annual expenses for the patient. I myself recently faced an $1,800 bill for a cancer screening. I could afford it, but I didn't want to, and I'm sure many people can't. As a result, we strongly support this legislation because it facilitates affordable access to early detection and prevention. So I hope you will join me in supporting HB 830.
Thank you so much.
Thank you.
No, thank you. Hold on a second. I'm going to open it up for questions. 1 second, please. Are there any questions for this witness? Seeing none, thank you very much for being here. We do have the Rare Gen Youth Network. If you can come up, please. I believe that's Kartik Upalapati. Tell me how to pronounce your last name.
Upalapati.
Okay, that was good. Go ahead, if you could give us your testimony, that would be great.
Chair, Vice Chair, and esteemed members of the committee, thank you for the opportunity to testify today. My name is Karthik Upalapati, and I'm the president of RareGen, the world's largest high schooler-led patient advocacy organization dedicated to advocating for an equitable healthcare access for rare disease patients. I am here to testify in strong support of House Bill 830, which mandates essential coverage for genetic testing and cancer imaging, critical measures that save lives every day, yet remain out of reach for many due to prohibitive cost sharing. We support House Bill 830 because genetic testing and cancer imaging are fundamental life-saving tools, especially for those of us with the rare and complex conditions. In my own case, I live with lymphedema, a condition so rare and severe that it took a panel of 8 geneticists to accurately diagnose it. Without timely genetic testing, my diagnostic journey would have stretched even longer, deepening the physical and emotional toll on my family and me. For rare disease patients, the stakes are even higher when it comes to cancer risk. Certain rare conditions, like hereditary preanglioma syndromes or familial adenomatous polyposis, require advanced genetic tests to detect cancer predispositions. Yet many insurers either deny coverage or impose burdensome co-payments and deductibles that make these tests inaccessible. This is not just an inconvenience, it can be a matter of life or death. According to leading cancer organizations, 1 in 3 cancer deaths could be prevented with early detection, but these interventions only work if patients can afford them. We have seen firsthand in the rare gen community how cost barriers delay care and lead to later, more complicated treatments for patients with rare forms of cancer who often have higher mortality risks. This not only drives up healthcare expenses in the long run, but also causes irreparable harm to patients who could have benefited from earlier targeted interventions. We strongly urge the committee to give House Bill 830 a favorable report. Thank you for your time and consideration.
I want to thank you for sharing your personal story, and I'm so glad you're here with us, okay? Are there any questions? I really appreciate your testimony today. You have a blessed day, okay? I would like to hear from Matt Celentano. And Matt, you're not going to have any friends today. Although Delegate Martinez says I'll be his friend.
Madam Chair, members of the HGO Committee, your friend.
It's an inside joke for those of you that are out there.
Hopefully still your friend, Matt Celentano, on behalf of the League of Life and Health Insurers of Maryland, opposed to House Bill 830. While we certainly want beneficiaries to receive all preventive services in a timely manner, we're concerned that the bills or the tests in this bill do not provide the medical effectiveness and accuracy that we expect in covered services. Although genetic testing is highly accurate in identifying genetic variations, detecting a variation associated with an increased risk of cancer does not guarantee that the patient will develop the disease. Only about 10% of cancers may be caused by genetic inheritance. In the Maryland Healthcare Commission's interim study of this legislation, they wrote, quote, providers noted that the percentage of individuals that will test positive for a cancer genetic variation are in the minority. And since individuals who test positive for a genetic variation represent a small percentage of the population, and cancer screenings are generally covered by insurers as a preventive service, they also noted that these tests are only about 40 to 50% accurate. The study also showed that private health insurance already covers genetic counseling and testing with low or no out-of-pocket costs for people with a family cancer history. We believe this bill is repetitive and creates just added cost to the system. This was echoed by multiple physicians on the MHCC, on the commission, that said that the approach was not medically necessary and would only add cost to the system, as the tests are not remotely accurate. They wouldn't recommend that legislation move forward. Multiple commissioners also mentioned that the explosion of direct-to-consumer tests in this space, which the tests are even less accurate, would be adding additional consumer anxiety. The proponent of the legislation mentioned that it was only a very small percentage of premiums and costs. It actually translated, if you look at the study, to 53 cents per member per month. Usually, you'll hear us come in and talk about the added cost of the system. On mandate bills, when the commission comes back with anything over 5 cents per member per month, we get anxious. This is 53 cents per member per month. We ask for an unfavorable report.
All right. So if you were wondering if he had friends, that was why. Just kidding. It's okay, Matt. We love you here. Matt Morgan, Delegate Morgan. You're welcome.
Matt, I actually had some genetic testing myself. I got diagnosed with a rare cancer about 1.5 years ago. Went through the whole genetic testing over at Georgetown. And the reason for that was, it was really to protect, I already had it. It was really to try to give some clues of whether, my children or other family members might have it. Can you just give us some background of what does that cost? And what, the genetic testing available, the one I had was very specific to the type of cancer that I had, but it didn't cover like everything. I mean, because most of the tumor marker in genetic cancer, like personally, I had medullary thyroid cancer. That's very different than, pulmonary thyroid cancer or dealing with melanoma or, maybe even some other cancer like prostate or colon. I mean, there's a lot of different cancers. Would one genetic test really cover all of them?
Well, Delegate Morgan, I could say, I don't know the answer specifically to your question. I'd have to go back. But my understanding is that the genetic testings, the tests in general are pretty costly. And because of the lack of accuracy, there is hesitancy to cover tests that if you find something, you're going to go get other covered services that you already have. So it's just layer upon layer of cost that doesn't get us any more information.
I see. So if you come back with an unknown genetic thing,
you're going to be covered regardless.
Go get more imaging or something like that.
Correct, and it's going to be covered anyway. And also with a family history, you're going to be covered regardless. So this is sort of, we just think added cost, but doesn't get you anything more. The other thing that we talked about before was that the ACA doesn't cover it. The ACA U.S. Preventive Task Force mandates that carriers have to cover preventive services with no cost share. This doesn't fall into that bucket because of the lack of accuracy.
Okay, thank you. Thank you, Madam Chair.
Delegate Kaiser. You're welcome.
Thank you, Madam Chair. Trying to find the testimony I was looking at. Thank you, Matt. I had a question. Would you be more in favor of this if there were more risk factors that someone had a hit than more than just their family history? Would that make a difference?
Well, I think that, Delegate Kaiser, if you have more hits, so to say, or more factors, it is going to go into the overall bucket of what cover services are going to have. So family history is one example of that. But if you have other factors that lead to more testing, it's going to be covered anyway. This is a blanket sort of coverage of a test that might not be necessary for your particular situation.
Okay, because I was just trying to understand philosophically the direction you were going in by saying, because if there's multiple risk factors, because we had a bill a few weeks ago, famously House Bill 666, which was saying that you only needed 3 out of 4, and you all still rejected that. So it seems like even when someone has 3 out of 4 risk factors, you were in opposition to a bill.
That would be the calcium score testing bill?
Yes.
Yes, Delegate. I remember it well. That was a completely different situation. The risk factors that were identified in that bill, we had medical from some of the physicians from the carriers who say that actually could be harmful, and that was a whole different situation. It's not a medical effectiveness. It was some of the factors that were laid out and the test that was associated with calcium score could be harmful to the patient. So that was a concern just on the medical sort of utility of the test.
Okay, thank you. I appreciate it.
Delegate Chisholm, followed by Delegate Bagnall.
Thank you, Madam Chair. You indicated that it's not covered because of accuracy.
Not immediately covered, Delegate Chisholm. If your doctor, there's always an exemption policy for any of these tests. So just not immediately covered, but if there are multiple factors, it certainly can be.
I'm just curious and interested to know, are the results getting better? Are they getting more accurate? Because with innovation, and the reason I ask that is, are we going to get to the point where it's covered 100%?
So I think that eventually these kinds of tests are going to get better and better, and we're going to have a clearer picture. I can't say, but I remember, growing up, my grandmother, I have a bee sting allergy, so they just put mud on it, right? Things have changed. Epinephrine has come in. There's going to be sort of different testing and different medical necessity that actually increases with technology and time, and I can't say what's going to happen in the future, but I know these tests are getting better and better.
So you're telling me I shouldn't be eating the Vaseline or the Vicks Vapor Rub my grandmother used to give me?
I mean, you can.
It worked.
What did it do?
Thank you.
Delegate Bagnall.
Thank you, Madam Chair, and thank you, my friend Matt, for being here. I just wanted to give you an opportunity to clarify something, because I thought I heard you say if you find out, you're going to come back and get other covered services. And I'm not sure that was what you said or what you intended, because I'm not sure I understand what the problem would be with getting.
I think it's a medical effectiveness of the testing, Delegate Bagnall. So I think there is a reluctance to cover these tests that are not effective, but if you have a bunch of risk factors that put you into a different bucket, there's going to be a series of other tests that are more effective. And I think that if you point to page 6 of the Lewis and Ellis study from MHCC, they talk about that medical effectiveness, and it says, While genetic testing is highly accurate in identifying genetic mutations, like I said before, but it says, for example, it is estimated that 45 to 65% of women with the BRCA gene variation, or BRCA1 gene variation, and 45% of the BRCA2 gene variation will develop breast cancer by age 70. In comparison, the average risk of women developing breast cancer is only about 13%. However, overall, less than 10% of women diagnosed with breast cancer will have a BRCA mutation. So the test isn't necessarily isn't going to tell you that you're going to develop cancer. It's just going to be an indication. There is other testing we think that we've been told that is much more accurate and will give a better picture with the physician to figure out what your course of action should be.
Thank you. Thank you for clarifying.
Any other questions? I don't see any, but I do have a question for you, Matt.
Yes, Madam Chair.
What is the denial rate
Madam Chair, I have absolutely no idea.
when a provider makes a request?
I do not know. I can try to look into it. I know
Can
that
you
we have a
please?
series of pieces of legislation further this afternoon. Will help clarify that for sure.
Yeah.
I will note that, Madam Chair, I am opposed to this bill, but I'm positive on 3 upcoming bills, so I hope you're proud of me.
I am, Matt. And thank you for working with us. We appreciate it. I don't see any other questions, so thank you very much for being
Thank you
with
very
us. I do want to ask the Rare Gen Youth Network, how many members are here today? Can you get up? Please stand up. I just wanted to recognize you. I know only one of you testified, but I wanted to just say hello, okay? Yeah, thank you. Is he signed up? What is your name? Did you sign up to give testimony?
Us 3 signed up, yeah.
Okay. What are your names?
I'm Ishan, he's Viraj. I'm Viraj, he's Karthik.
Okay, I don't see you on here.
Oh, I was for the Preserve Telehealth Access Act.
Oh, okay, that's next. Okay, that's next. Okay, so we have, but welcome anyway. We love it when young people are involved, okay? We love it. Let's go on to, we have 2 virtual ones, Stephanie Reed and Marlena Barbera. Will you be so kind and bring them up? Gotcha. Good afternoon. Good afternoon, Ms. Barbera. Will you be so kind and give us your testimony?
Yes. Good afternoon. My name is Marlena Barbera, and I'm here today as both a patient and a provider, someone who has seen firsthand the critical importance of genetic testing in cancer prevention. I'm a lymphedema therapist, a subspecialty of occupational therapy that focuses on managing swelling, often resulting from lymph node dissections secondary to oncology surgeries. Additionally, I'm a proud member of the Maryland Occupational Therapy Association, which represents, supports, and advances the practice of occupational therapy in Maryland. I'm here in support of House Bill 830 because I have lived the reality of what happens when genetic testing is not covered. Due to a very limited family history, I had no way of knowing whether I carried a hereditary cancer mutation following a scan that revealed high-risk cells in my breast. Despite this uncertainty, my insurance would not cover genetic testing, forcing me to pay out of pocket just to obtain the critical information I needed. Because I had this information, I made the difficult decision to undergo a prophylactic mastectomy. I was fortunate that I could afford this test, but many cannot. And without coverage, this kind of testing loses its preventative power. A genetic test is far less expensive than chemotherapy, radiation, surgery, and years of follow-up treatments. Studies show that preventative measures save the healthcare system millions of dollars by reducing the need for late-stage cancer care. Yet, too many people are unable to access these tools because insurance won't cover them. On the provider side, as a lymphedema therapist, I have treated countless patients who were unsure if their cancer was hereditary until after their diagnosis. Had they known earlier, they might have pursued enhanced screening or preventative measures. Instead, they face costly, life-altering treatments. House Bill 830 is about ensuring that all Marylanders, regardless of their financial situation, have access to life-saving information. I urge you to support this bill and help create a healthcare system that prioritizes prevention over crisis care. Thank you.
You're welcome, Stephanie Reed. Good afternoon.
Hello, Madam Chair, and thank you for the opportunity to speak today. My name is Stephanie Reed, and I currently reside in Carroll County, Maryland, and I volunteer as a peer navigator and patient advocate leader with FORCE. I'm testifying today to ask you to support HB 0830 to help reduce costs for high cancer risk constituents. I'm extremely familiar with the burden this can put on a patient, as I am BRCA1 positive myself, and I have about a 60% chance of developing cancer in my lifetime. I pursued testing for my mutation after losing several family members to cancer. I've had a preventative hysterectomy, and I regularly monitor for other cancers, such as breast, skin, pancreatic, and colon cancers. I have a team of 9 doctors, and I complete over 22 separate cancer-related scans or tests each year. Each of these doctor visits and tests comes with an associated cost, both in time and money. My estimated annual out-of-pocket costs for preventative BRCA care are in the thousands of dollars, even with my health insurance. There seems to be a very big disconnect in the insurance industry with how the costs of genetic cancer testing and preventative care is, or more likely, is not covered. I'm constantly calling my insurance company to ensure everything is in order and fighting for approvals. I just had a service denied last week. I consider myself quite fortunate in that I'm able to afford the copays, deductibles, time off of work, and other costs associated with my genetic mutation, but it's not escaped my notice how detrimental these things are to others who need this care. Folks with these mutations are already carrying the weight of cancer, whether directly or preventatively. We should not have to make a choice to complete our care due to costs. We should not have to go bankrupt to stay alive. With your passing of House Bill 0830, we can help all Marylanders with genetic mutations like me live longer, healthier, and hopefully cancer-free lives. I thank you for your support for the bill and for your time today.
I want to thank you both for sharing your stories, your personal stories, and I pray that you stay healthy, okay? Let me open it up for questions. Are there any questions for these 2 witnesses? Seeing none, thank you for your time today. We really appreciate it. And this committee concludes the bill hearing on House Bill 830. Thank you so much. Have a blessed day. Next, we have House Bill 995, and if I may have Marie Grant from the Maryland Insurance Administration, Tori Bayless, Stephanie Snitcher, if you can correct me when you get up, Andrew Nicholas, and Robin Elliott. If you can have a seat, please, and just bring enough chairs. Okay. Go ahead and have a seat. You can start sitting, that would be great. Okay. Thank you so much. So good afternoon, committee. I was going to say vice chair, but she went outside. And members of the committee, I am pleased to present to you House Bill 995. As you know, I'm Jocelyn Peña-Melnick. This is a work group to study the rise in adverse decisions in the state healthcare system. And we hear this often in this committee, right? We just heard it. I asked the question, how often are the denials, right? How often is it done? What's the percentage? So adverse decisions, which include claim denials, prior authorization denials, medical necessity denials, and coverage restrictions, may prevent patients from receiving timely and oftentimes, as you heard in the bill that we just had, life-saving care. These decisions often lack transparency, create financial burdens, and limit access to critical treatments. It is a problem. As more Marylanders navigate a complex healthcare system, insurers' decision on prior authorization and medical necessity determinations have serious consequences for people. Too often, patients experience unnecessary delays. I want you to think about how often have you experienced it? A loved one. How often have you experienced a treatment denial? And providers face administrative barriers that interfere with patient care. My doctor tells me all the time I have to submit again 2 and 3 times, and she doesn't have the time, and she has many patients. The absence of data on the occurrences of these denials makes it challenging for us to assess the full scope of the problem and to try to come up with some policy decisions to solve the problem. House Bill 995 establishes a work group to examine the root causes of the increasing number of adverse decisions, evaluate reporting requirements, and propose solutions to improve patient protection, which is so important. The work group will be composed of policymakers, state health officials, insurers, providers, and patient advocates that will analyze the current trends and assess how denials impact care. And they will make recommendations to improve the system, right? And basically look at the appeal process. The bill is a critical step in addressing this systemic challenge. And I want you to listen carefully, respectfully to the data that the hospitals are going to present to you and the numbers, because they are alarming. They really are. And I'm hoping that this committee can approve House Bill 995, give it a favorable with amendments. We have some amendments that will be discussed by the panel. Thank you so much. Who would like to get started? All right. I think the Maryland Insurance Administration has been nominated and she accepted. So why don't you get started?
Thank you so much, Madam Chair, Madam Vice Chair, committee members. Marie Grant on behalf of the Maryland Insurance Administration here in support of House Bill 995 today. The chair explained it beautifully, the reasons for this work group. Maybe just a couple of notes from our perspective. I think, as you all know, we regulate a little over a third of the commercial insurance market in Maryland. We do have a very robust adverse decisions law, appeals and grievances law, where adverse decisions are required to be reported in a certain manner. And then there are appeals processes, and we'll be talking about that more with other bills today as well. But this work group is an important opportunity to look at, I think, not just the market I regulate, which is going to be really important, but to understand what's happening statewide across different markets and to see how we can help standardize and streamline the process. Certainly as a regulator, there is a place for prior authorization, there's a place for utilization management, but I think what we're seeing a pretty disturbing rise even in our data. And we, I think, need to get to the bottom of it and need to make sure that we're protecting Maryland consumers. So with that, urge a favorable report and look forward to working with you all on this important issue.
Thank you. And thank you for your work and congratulations on your new appointment.
Thank you so
As Secretary of Maryland Insurance Administration, we're very proud of you. Who's next?
Thank you, Madam Chair, members of the committee, Madam Vice Chair, members of the committee. My name is Andrew Nicholas, representing the Maryland Hospital Association. It's great to see you all again. Thank you so much to the Chair for putting in this bill. The issue of rising health insurance denials is a critical issue to hospitals, to providers, and most importantly, to the patients that we serve. And this bill provides an excellent opportunity to drive reform in this space. So just a quick overview of what hospitals are experiencing. Insured healthcare denials have increased significantly since the year 2013, and with a rapid increase over the last 6 years. The most drastic increase over that time has been in the commercial payer space, with medical necessity denials going up 79% in the last 6 years. And so that's not denials related to, typos and errors, getting a Social Security number wrong. These are denials based on deeming a procedure medically not necessary. We've also seen an increase in denials from commercial payers in emergency room care. Commercial ED denials have more than doubled in the last 6 years. So what that looks like is in FY19, ED claims received 6% of them received a denial, and fast forward to FY24, 15% of claims coming from ED care going to commercial denials commercial payers are receiving a denial. That's a significant increase and has a significant impact on hospitals and providers. Now, although we have seen the greatest increase in the commercial payer space, the rates for MCO denials have remained constant over the last 6 years, but they remain the highest overall denials that we experience. So it's not isolated to commercial payers, even though they've seen the most increase over the last 6 years. And so this has an impact on patients and providers, as I said, leads to delays in necessary care, leads to higher out-of-pocket costs for patients, and leads to providers not being able to spend as much time at the bedside as they'd like as they deal with denials and appeals processes. And so for those reasons, we urge a favorable report on this bill so we have the opportunity to lead to greater transparency, accountability, and reform in this space. Thank you.
Thank you. Next, please.
sort of the voice off camera here. So I'm Tori Bayless, the CEO for Luminous Health, and thank you, Madam Chair, for introducing this bill, Madam Vice Chair, members of the committee. As CEO of Luminous Health, I also support the House Bill 995. I'm not sure if anyone had the opportunity to see the front page of the Wall Street Journal today or the lead story. The lead story was health insurers deny 850 million claims a year. The few who appeal often win. So if you hit a paywall, I could give you a copy of the article. But we do urge support for this bill as well. We know that in Maryland, we have a very unique total cost of care system, and hospitals are encouraged, incentivized, and mission-driven to provide high-quality, safe care, and we also want to have a system that is affordable. What we find often through some of the payer practices, they're quite burdensome relative to denials, prior authorizations, or repeated requests for medical records that really don't add any value to the system. So I think you've heard me say in other forums, I don't think we want to be proud of a system that saves money based on denials or rate suppression. We want to be able to focus on preventive care. We want to be able to focus on appropriate utilization. We want to be able to focus on care in the right setting at the right time. So we do urge support for this, but I want to yield the rest of my time to my colleague, Luminous Health Chief Financial Officer Stephanie Schnittger, and she can provide a few more details about what we actually experience within our system and offer some ideas around what the work group may consider going forward. Thank you, Madam Chair.
Good afternoon. Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Stephanie Schnittger, the CFO of Luminous Health. I joined Luminous Health in April of 2024, and this is my first exposure to the unique Maryland model. As Tori mentioned, the administrative costs associated with running a hospital and healthcare system is astronomical. There are many studies out there, but administrative waste accounts for roughly 25 to 33% of total U.S. healthcare spending, with billing and insurance-related costs being the most significant contributor of these expenses. In Maryland, this problem is worsening. For example, at Luminous Health, we saw our billing and collection costs rise from $12.9 million in 2019 to over $32 million in fiscal year 2024. At that same time, our write-offs of our revenue rose from $13.8 million in 2019 to over $46 million in fiscal year 2024. That's the definition of a horrible return on investment. Further, what we're forced to do is invest even more in revenue cycle performance improvement, in technologies, in resources, in people, process, and technology to enhance our capabilities to try to counter the technology that insurance companies put in place to deny claims. That's furthering the definition of insanity. Hospitals should not be focusing these resources on spending on administrative costs. We need to better position those dollars toward patient care. We should not be forced to spend more on administrative processes just to fight payment denials. Addressing these provider-payer relationships are essential to sustaining the Maryland model and ensuring hospitals can continue to provide high-quality care. We come with some ideas that should be assessed under this work group, in our opinion. Some of these could come around in the strengthening of the Medicaid program in Maryland, and I think the work group would be a particularly great place to study some of these ideas. We could look at the oversight of the MCOs in Medicaid and look at profit-sharing type of.
You have 30 seconds because she gave you 30 seconds.
Reassess the financial reporting and potentially and the integrity of the medical loss ratios. For commercial insurance, we could standardize payment policies to reduce administrative burden. We could increase the transparency and provide payer scorecards to ensure quality and compliance. We are not just here to voice concerns. We offer ideas, and we welcome this bill and participation in any work groups to help further these ideas, to help improve quality and care that we can deliver for the community and the residents of Maryland. Thank you.
Thank you, and welcome to Maryland.
Thank you.
Next, please, Ms. Elliott.
Good afternoon. Robin Elliott. I'm here today on behalf of the Maryland Community Health System, which is a network of federally qualified health centers across Maryland. So I think everyone here knows quite a bit about federally qualified health centers. Their doors are open to everyone regardless of ability to pay. They do take commercial insurance, and of course they do take Medicaid. Roughly overall, about a third of their patients are with commercial insurance, a third with Medicaid or Medicare, and about a third uninsured. and there's variations. What they tell me is that the cost of dealing with rising adverse decisions has gone up significantly. I was listening to my hospital colleagues talk about that. For them, what it impacts is their ability to provide uncompensated care, which is so key. They are the front doors to our healthcare system, keeping people healthy, hopefully out of the hospital. They are critical partners. Their billing systems are complex. As I think everyone here knows, they provide a range of primary care. Sometimes they provide OB. They provide a full range of behavioral health services, and many FQHCs also provide dental care. So their billing operations are complex, expensive, and getting more expensive. And they would really like to reinvest those dollars into the communities that they are serving, who are so underserved and so needing of additional services rather than spending those dollars on administration. With that, if there is a way for federally qualified health centers to perhaps have a seat on this commission and contribute in any way possible, they would be very, very pleased to help with the efforts. Thank you.
And thank you for everything you do with us, okay? I am going to open it up for questions now from the committee for this panel. Are there any questions? So I have a clarifying question. Andrew, you stated, you gave us percentages, but can you give us numbers?
I can get those to you. Yes,
Okay.
I have those, not at my fingertips, but I can
Thank
get them
you.
to you.
I appreciate it, because I saw them and I know that they were alarming. But I will let you submit it to the entire committee. Since I like to share, we give it to everyone. Since there are no questions, thank you so much for being with me and the committee today. We next have Daniel Shattuck, and we have Donna Kaufman. Are they here? Oh, okay. Good afternoon.
Good afternoon. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Dana Kaufman. I'm here on behalf of MedChi. We are in support of the bill for the reasons that you've heard from the previous panel. I do want to just point out one provision in the bill that I think is very important. It's page 3, lines 19 and 20, and it talks about standardizing the process for reporting grievances or filing complaints and appealing adverse decisions. We do think that that is very important. As I have said before, the process can be very cumbersome for physicians and patients to appeal a denial. You have to go through an internal process, and then even to get to filing a complaint with the insurance administration can be very time-consuming, and it can be a lengthy process just to submit the paperwork. I think if we were able to streamline, we would see more patients and physicians being able to appeal those denials and file complaints. And I think that's important because if you look at the appeals and grievance, while you don't have a lot of complaints being filed, when they are, 70% are overturned in favor of the patient, meaning that 70% would have gotten those benefits much earlier. So we look forward to working on this work group. We appreciate MedChi having a position, and we do hope that we can revise this process. So thank you very much.
And thank you. Are there any questions for this witness? Seeing none, thank you so much for being with us. This concludes the bill hearing on House Bill 995. Next, we're going to go, because they're related, to House Bill 848. And if I may have Donna Kaufman, Jake Whitaker, Marie Grant, and Daniel Shattuck, please. Robin Elliott, if you can come up. And this testimony for the committee is going to be provided by my wonderful, amazing, intelligent fellow who is getting a master's from Hopkins, and he's also a doctor. He'll tell you where, and he's going to be providing the testimony. We get started, please. This is for the committee, House Bill 848, Adverse Decisions, Reporting and Examinations.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the HGO Committee.
Move the microphone closer to you. Thank you.
Yeah. Good afternoon, Madam Chair, Madam Vice Chair, and members of the HGO Committee. My name is Emmanuel Animashao. I am a healthcare management professional and trained in Nigeria as a physician and currently a health policy fellow at the Johns Hopkins Health Policy Institute. Currently working with the committee. I am here today honored to present this testimony on behalf of Madam Chair. Our healthcare system continues to stand. I am presenting House Bill 848 for the records. It's on adverse decisions, reporting and examinations bill. Our healthcare system continues to stand at critical crossroads that we cannot deny, where the fundamental promise of medical care has been systematically undermined by an increasingly complex landscape involving several players. At the heart of this challenge lies a growing epidemic of health insurance claim denials that threatens the very foundations of patient care and healthcare accessibility. Recent comprehensive research from the Kaiser Family Foundation paints an alarming picture of this deeply troubling trend in insurance practices. In 2021, insurers were denying an average of 17% of all claims submitted. However, that average masks the true extent of the problem. Some insurance carriers have pushed the boundaries of what can be considered acceptable practice, with one insurer reaching the shocking milestone of denying 49% of claims in a single year, and another achieving an almost unbelievable 80% denial rate in 2020. These national trends are mirrored in our own state, with even more troubling implications. The Office of the Attorney General of Maryland reported that in the year 2023, Maryland health insurance carriers reported 135,922 adverse decisions, a staggering increase of 47,383 from 2022. Some insurers showed particularly dramatic spikes in denials. Mamsi Life and Health increased denials by 495%, Optimum Choice by 190%, and United Healthcare by 181%. Perhaps most concerning is that carriers reversed less than 1% of these denials on their own initiative, while only 8% of cases were challenged through consumer grievances. These numbers tell us not just about the scale of denials, but about the systemic failure to protect patient interests. Indeed, these are not mere statistical anomalies or isolated incidents. They represent a systemic failure that has profound implications for patients, for healthcare providers, and the entire medical ecosystem. To understand the true magnitude of this issue, we must consider the economic and human cost of these widespread claim denials. The human and financial toll of these denials is staggering. A survey from 2019 estimated that the increasing rate of claim denials imposes a burden of approximately $262 billion annually on healthcare organizations. But the real cost is not measured in dollars. It is measured in delayed treatment, worsening health conditions, and the psychological burden on patients who must fight bureaucratic battles while managing their illnesses. Healthcare providers find themselves trapped in an increasingly complex administrative maze, dedicating unprecedented amounts of time and resources to appealing denied claims, navigating bureaucratic hurdles, and attempting to secure necessary treatment for their patients. This crisis disproportionately affects our most vulnerable populations, as research has shown. Furthermore, research indicates that nearly 60% of insured adults are experiencing significant problems with their health insurance, with claim denials emerging as a primary source of these challenges. This issue is a human rights concern that disproportionately affects the most vulnerable populations in our society. House Bill 848 emerges as a critical legislative response to this growing crisis. The bill is not designed to malign insurance carriers or create unnecessary bureaucratic obstacles. Instead, it represents a carefully crafted mechanism to bring transparency, accountability, and human consideration back into healthcare decision-making process. The legislation introduces a robust and comprehensive reporting requirement that goes beyond surface-level compliance. When an insurance carrier's adverse decisions for a specific type of service increases by more than 10% in a calendar year or 25% over 3 consecutive years, they will be required to provide a detailed reporting that includes explanation and comprehensive information about the types of services affected and the patterns of denials that have emerged, a mechanism for understanding and potentially correcting systemic issues that impact patient care. The bill empowers the Maryland Insurance Commissioner with insight and investigative capabilities by providing the authority to conduct thorough examinations, therefore creating a proactive oversight mechanism that can identify and address potential barriers to healthcare access before they become systematic problems. Some may argue that this creates additional administrative burden for carriers. However, this information is already being tracked internally by insurance companies. We are simply requiring transparency when denial rates spike dramatically because transparency is essential for protecting public health. Our existing quarterly reporting requirements provide basic data about adverse decisions, but they do not tell us why denial rates are increasing or what changes in medical management might be driving these increases, a gap that will be addressed by this bill. The potential impact extends beyond immediate claim processing. It sends a clear message that healthcare is not a privilege to be arbitrarily granted or denied, but a fundamental right that requires careful, considered, and compassionate management, and it has the power to reshape the entire healthcare conversation in the state of Maryland, creating a more accountable, patient-centered approach to medical insurance for all Marylanders. The evidence before us is clear and compelling. The surge in denial rates we are witnessing demands immediate legislative action. When insurance carriers can increase their denials by hundreds of percentage points in a single year with minimal oversight or consequences, we fail to protect Marylanders' access to healthcare. I therefore urge this committee to stand with Marylanders by issuing a favorable report on House Bill 848. Every day we delay action means more people facing denials of necessary medical care without recourse or explanation. Thank you for your consideration.
Thank you. I don't think you have anything else to say, do you, after that? That was excellent testimony. Go ahead. Who will be next? Thank you for your work, Iman.
Thank you, Madam Chair.
Go ahead.
I can go next. Thank you, Madam Chair. Thank you for that wonderful testimony. Hard to follow, so I'll keep it short. Madam Vice Chair, committee members, Marie Grant on behalf of the Maryland Insurance Administration, here today in strong support of this legislation. I think you have heard, you will hear a number of analyses and references about what we're seeing, I think, in Maryland and nationwide with increases in adverse decisions and impacts on patients as well as our healthcare provider community. But I just want to talk a little bit about our data in our adverse decision process. We have seen the number of adverse decisions over double since 2015 here in Maryland in the market that I regulate. So that is determinations on medical necessity. At a time, so that's numbers, but then it's at a time when actually the fully insured market has shrunk a little bit. So as a percentage of our membership, that was one of the things we took a look at. Adverse decisions were a little under 5% back in 2015. They are over 12% now, and that increase is largely due to increases in decisions related to pharmacy. That's what we're seeing in our data. But there are other services, and we do collect the data by service that we are seeing some rises in as well. And so what this bill does, it's simple but very important. It requires when those increases are happening for a carrier that they are immediately reporting to us why. Why is this increase happening? It gives us the ability to take a closer look at what is going on with those carriers' practices and allows us the opportunity to make sure our carriers are in compliance with our laws. So happy to answer any questions and urge a favorable report.
Thank you. Thank you for your work. Next, please.
Thank you, Jake. Good afternoon, Robin Elliott. I am here today on behalf of the Maryland Community Health System, which you just heard about, a network of FQHCs, the physician assistants, and the school-based health centers. Very much in support of the bill. All three organizations had robust discussion about the impact of the increase on adverse decisions on themselves as practitioners and, of course, patients. I do want to highlight, because it came up in the other bill, some of the discussions those groups had was about Medicaid. And I know Medicaid is not addressed in the existing reporting law, but for FQHCs, which see a huge number of Medicaid enrollees, as well as school-based health centers who are almost entirely Medicaid enrollees or uninsured students, the Medicaid market and the Medicaid impact is significant. So whether it's in this bill or it's discussed in the work group, we would just ask the committee for your support in really thinking about the Medicaid problem in addition to the commercial market. Thank you so much. Appreciate your time today.
Thank you for being with me. Just for a second, Attorney General Brown, I'm going to call your bill next, okay? When we're done. Thank you. Go ahead.
Thank you, Madam Chair, members of the committee. My name is Jake Whitaker on behalf of the Maryland Hospital Association in strong support of this legislation. The hospital field, as you saw in the last hearing, is in very strong support of any legislation that's intended to enhance transparency and accountability in the adverse decision process. Just wanted to rattle off a few other stats that my colleague Andrew didn't get a chance to mention during the last hearing that we find especially alarming. So over the last 6 years alone, the total value of denied claims has more than tripled, and reaching a staggering $1.4 billion in just the last 3 years alone. Also in 2024, we've seen the highest denial rate in 6 years. Also in the past 6 years, the commercial ED denials have surged by 116%, with the associated costs going up by 117%. So these are really concerning figures. These affect the ability for us to deliver care. It has our providers wasting time working through administrative processes rather than caring for patients. So we really appreciate this committee's leadership in really taking this issue head on and would request a favorable report for this bill. Thank you.
Thank you for your work. Next, please.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Again, my name is Dana Kaufman. I'm here on behalf of MedChi and several other healthcare practitioner organizations. We, again, are in strong support of this bill. This committee worked for 2 years on the most recent prior authorization and utilization review management legislation. That was really the first comprehensive look that the appeals and grievance process had received in almost 2 decades. But all of the protections that we have in that bill that are some of the best in the country are only as good as if they are enforced and complied with. So we do think it's very important to have this trigger for the Maryland Insurance Administration to be able to really take another look and, if necessary, to implement any enforcement so that the protections that you passed for your constituents and for the physicians and patients in the state actually do come to fruition. So we would urge a favorable vote. Thank you.
Is Daniel Shoddock here? All right, so let's open it up for questions. Are there any questions for this panel from the committee? Vice Chair Collison.
Thank you, Madam Chair, and thank you for the bill. So I had a question for Jake.
You gave a number when you said that the value of the denials. I'm just curious, how do you calculate the value of the denials? What went into that formula? I'm just curious.
Yeah, I'd be happy to check with our data team on the exact methodology and circle back with you, Madam Vice Chair.
That'd be great. Thank you, Jay.
Delegate Taveras.
Thank you. The question that I have is that would it be possible that in these denials, the denials are being done through artificial intelligence and the impact that that would have in this process?
Maybe I can start, Delegate Taveras. I think that there is a role that artificial intelligence may play in some of this and algorithms. There is another bill this afternoon on just this topic. It is the view of the Maryland Insurance Administration, though, that our law requires a person at the end of that decision, the person be making it, and it's certainly, we believe that's current Maryland law today. But we are, again, stay tuned, another discussion about the role of artificial intelligence and understanding and reporting as part of all of this.
That's House Bill 820, introduced by an amazing delegate, Delegate Hill.
Yeah, just wanted a flag.
Thank you. So they're all connected. Thank you for the question. It's a very good one. Are there any other questions for this panel? Seeing none, thank you so much for your work. Excellent testimony. So this actually concludes the bill hearing on House Bill 848. We are now going to go, because I promised him, the Attorney General has House Bill 576, and it's healthcare facilities, nursing homes, and assisted living programs, video recordings. Good afternoon. Good afternoon, Attorney General. How are you?
Well, no, you take that one. This slide over here. Oh, I'm doing fine. How are you doing, Madam Chair?
I'm doing well. Thank you for asking. And you can get started when you're ready.
Thank you, Madam Chair and members of the committee. And for the record, I'm Attorney General Anthony Brown, testifying in support of House Bill 576. And I want to thank you for the opportunity to provide testimony today. The Office of the Attorney General is committed to investigating and prosecuting abuse and neglect of vulnerable adults, particularly in nursing homes and assisted living facilities. And as I did, I think, a few days ago, I thank you very much for, during the past 2 years, giving us greater resources and greater tools to do just that. Studies show that 1 in 5 adults aged 60 and over experience elder abuse, and the true scope is likely underreported. Vulnerable victims are often nonverbal or suffer from dementia, making it difficult for them to advocate for themselves. This bill requires video recording in common areas of long-term care facilities with footage retained for at least 120 days and available for law enforcement inspection. Certainly 120 days isn't a magic number. It could be less. You could make it longer. Certainly want to work with the committee on that one. Opponents have raised concerns about the cost of video recording equipment and data storage, but the cost of inaction is far greater in terms of harm to victims. Video evidence can be crucial in securing justice for victims of abuse, as shown in several recent cases. And I think during Mr. Shirley's testimony, he's going to put a few screenshots from videos on the monitors in front of you.
They're in the case file.
They're in the case file, so no monitors, no video. And we're certainly willing to make available to the committee any of the video footage that you'd like to see. All of it's in the public domain because they supported successful criminal prosecutions. The bill limits video recording to common areas, addressing privacy concerns while ensuring protection for vulnerable adults. There have been concerns raised by the Department of Health and the Office of Healthcare Quality regarding implementation, and we believe that the committee can address them with appropriate amendments. Senate Bill 465 does not create a mandate for the department. It allows them to adopt regulations to carry out this section, leaving enforcement flexibility to OHCQ. Instead of an extensive approach, OHCQ could consider a self-reporting requirement where facilities document compliance during licensing and renewal without additional inspection costs, and Mr. Shirley can speak more to that as well. So the Office of the Attorney General, we strongly urge a favorable report on House Bill 576. Thank you, Madam Chair.
And thank you for your work. Who will be next?
Good afternoon, Madam Chairman and distinguished members of the committee. My name is Zach Shirley, and I'm the Chief of the Medicaid Fraud and Vulnerable Victims Unit in the Office of the Attorney General. When I started this job, I never could have imagined the prevalence of abuse against vulnerable adults in our state. But every month, our unit receives around 30 to 40 reports of vulnerable adult abuse. And that's just what gets reported to us. Without fail, among those complaints are instances of unexplained injuries to those living in long-term care. Bruises, burns, and broken bones, injuries that common sense tells us don't happen on their own. Unfortunately, as is so often the case in our work, the victim cannot communicate or cannot remember what happened. These are the cases that keep us awake at night, the ones in which, despite our best efforts to find an investigative angle or a string to pull on, we simply cannot prove what happened. But then there's video. Video can change the trajectory of the cases I just described and provide a path to justice. In the bill file, you'll find 4 screenshots from different videos that were used to support successful prosecution. In the first, a 74-year-old dementia patient is seen being shoved to the ground by a geriatric nursing assistant. What you should know is that that man never got up again. His hip was broken, he developed blood clots, and because of his weakened condition, contracted COVID and passed away shortly thereafter. That video was taken from a camera in the hallway that caught the entire incident, and because of that video, his abuser is sitting in prison as we speak. In the second, we prosecuted a direct care provider for assaulting a developmentally disabled man at his day program. That camera was just outside the facility entrance. In the third, a care provider was prosecuted after she dragged a woman across the floor by her feet, kicked her, and tore out chunks of her hair. And in the final screenshot, you'll see a caretaker who was found guilty by a jury after a neighbor's doorbell camera caught him assaulting a developmentally disabled man in his care. These images are proof that House Bill 576 can change the landscape of long-term care in Maryland. Cameras are cheap, cameras are effective, and cameras can speak for those who cannot speak for themselves. And for that reason, I urge a favorable report on House Bill 576.
Thank you. Who's next, please?
Good afternoon, Madam Chair. My name is Tammy Bresnahan. I am the Senior Director of Advocacy for AARP Maryland. I will keep this short. AARP supports wholeheartedly HB 576, and we really do thank the Attorney General for bringing this bill forward and to you. We're here often about the quality of care in nursing homes, making sure that patients are safe, making sure they're inspected. We believe that this is another tool in the toolbox. We know that cameras are with us every day, everywhere we go, and we should be using them in our in the settings where our most vulnerable live. We ask you wholeheartedly respectfully for a favorable report on House Bill 576. Thank you very much.
Thank you. And Mr. Shirley, thank you for sharing those facts.
Thank you, Madam Chair.
Thank you, Tammy. Who's next?
Good afternoon, Madam Chair, members of the committee. My name is Jessica Spraker, and I'm a staff attorney at Maryland Legal Aid. I'm here today to express Maryland Legal Aid's strong support for House Bill 576. Maryland Legal Aid provides free legal services to some of the state's most vulnerable residents, many of whom reside in skilled nursing facilities and assisted living facilities. We regularly hear from clients who have suffered neglect, abuse, and unsafe conditions in these facilities. For example, we represented a client with dementia in a memory care unit who repeatedly wandered into unsafe areas due to inadequate supervision. Video monitoring could have documented the facility's failures and prevented harm. Another client, a nursing home resident, was denied meal deliveries. In cases like this, video recording in dining areas could verify neglect and hold facilities accountable. Unfortunately, there is no current law requiring video monitoring in these facilities, leaving residents at risk and making investigations difficult for families, regulators, and law enforcement. House Bill 576 would change that by improving transparency, accountability, and safety. This legislation will not only help prevent future incidents, but also provide critical evidence when abuse or neglect occurs. It will give families peace of mind, ensure facilities uphold the standard of care required by law, and protect those who cannot protect themselves. On behalf of Maryland Legal Aid and the many residents we serve, I strongly urge a favorable vote on House Bill 576. Thank you.
Thank you. And thank you for your work. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair, and the committee. I'm Bob Doyle. I'm with the Maryland National and Active Retired Federal Employees, or NARF, here today with our partner senior group, ARP, to strongly support HB 576. We thank you for the chance to give us, for us to provide you with a statement, which you have, but just a couple quick points. Doing research for this, while 14 states have, including Maryland, have regulations or guidelines on video cameras in nursing homes, Maryland would be the first to require this, and I think this is something this is a number one we could be proud of. Secondly, I want to talk about the 2023 Assembly passed a bill establishing a task force on preventing and countering elder abuse. Their work is continuing, but in their interim report, they had this troubling conclusion. It said, with the expectation of serious mental or physical infirmity or dependence increasing with advanced age of Marylanders, there's reason to suspect the incidence of abuse and neglect of older adults in Maryland will rise as this population increases. And third, I just want to echo General Brown's statement that are there costs associated with this bill? Of course there are, but I think the costs are much, I think the cost of not having this bill is going to be much worse than any industry cost associated with compliance with this bill. Thank you for the time to testify today, and I urge a favorable report on HB 576. Thank you.
Thank you. Thank you all for your testimony today. I'm going to open it up for questions. Delegate Hutchinson.
Thank you, Madam Chair.
You're welcome.
So, Mr. Attorney General, the cameras are not in the rooms. Is that correct? It's only the
bill, not in the room. Common areas only.
So in the cases that you've seen, what percentage of them are in the common areas versus that they are in the room?
I'm going to let Mr. Shirley answer that because he reviews all of them. The ones that we present in the file, only one of them of the four was in the private room, but it started in the common area, and you can see in the common area the worker drags the person into the private area where there aren't cameras. Now, I'm not suggesting that we should put them in the private area, but all of them that are in your file are in the common area.
Thank you. So the examples that we provided were primarily in common areas. It's hit or miss. Whether or not there's a camera in a private room, because there's no requirement that facilities allow that in Maryland. So sometimes we will get a complaint and we're like, I hope there's video, and we'll ask the family. And sometimes there is. We had an example in 2022, I believe, where there was a sexual assault on a very elderly woman. The nurse crawled into bed with her, but the family had placed a nanny cam, and we caught the whole thing on video. And we were able to successfully prosecute that case because it was right there, and it was real hard to deny. I will say that even sort of excising the issue of putting cameras in private areas, just keeping cameras in common areas, will provide evidence that can corroborate the story. A lot of times we'll hear from a victim. We had an example. I'll give you an example. We had a victim who said she was sexually assaulted while one direct care provider was in the bathroom, the other went into her room and sexually assaulted her. There's no camera in her room. We didn't catch any of that. But what we did catch from the common area was one direct service provider walking down the hall, going into the bathroom, and then about 5 seconds later, the other one walking down the hall and going into that resident's room. That corroborates the victim's story. It's not direct evidence. I didn't see the act, but she's telling a story that's backed up by video evidence. And so even just video from common area can be extremely helpful in prosecuting abuse.
Follow up, please. Yes. You said that cameras are cheap, but I actually looked into this a little bit prior to the bill hearing. I think in a larger home, I understand it could be upwards to almost $200,000 to put cameras throughout the entire facility, have it tied back to be able to be recorded. Assisted living facilities are smaller, so I'll use less than half of that number to do that. I mean, we always say that it doesn't have a fiscal note, but to the industry, it could have $125 million to $175 million impact to the industry if this bill is passed. And I also saw in the fiscal note that the Office of Healthcare Quality would have to come up with another $900,000 to be able to implement this as well. So I do think it does have a fiscal impact to the industry and to the state of Maryland.
If I could speak, Madam Chair, to the Office of Healthcare Quality, there are a number of ways, and the bill provides flexibility and certainly open to amendments working with OHCQ, MDH, the committee. I think the fiscal note contemplates an inspection program that is almost in and of itself, just looking at video cameras. I think they talk about 8 people that are doing this. And we believe, and I think amendments working with OHCQ, it can be done at no additional cost. And for example, when you go for a license renewal, just on the, a license application, you could have on the form, self-reporting, do you have a video system in common areas? On renewable, do you have? And then when OHCQ does inspect, which they're required to do annually, although I know there's concerns in the committee that that's not always being done, but when they do inspect, they'll be able to verify the accuracy of the information that was self-reported. So there, you can either go for the kind of like the Cadillac version, which is what that 8 pins that they're talking about and the big fiscal note, or you can go for I don't know what the less expensive car is, but I think you get my point.
It's not the Tesla. Yeah. So thank you. Thank you very much.
There is another bill coming up later on that Delegate Werman has that will allow cameras in the bedroom. So you will see that later on. Delegate Werman.
Thank you, Madam Chair, and thank you so much for reading this bill. As the chair said, I do have a bill coming up that deals with the cameras in the patient rooms, but I'm just wondering, I'm new to the committee, so I'm learning this. I just got appointed in August, but why did you guys focus on the common areas versus not focusing on the patient rooms?
Really to address the privacy concerns raised. There is at least one state, Oklahoma, I believe. 12 states that have them in the room. In the room. So there are 12 states that have them in the room, and we know that raises privacy concerns. We thought a very important first step would be the common area. Again, for the 2 reasons. One is often you'll capture the actual abuse, or you'll have corroborating evidence about the abuse.
Okay, thank you. One other question, if I may, Madam Chair. And, you know, with doing research for my bill, we came across the fact that the cameras have to be stationary. Did you guys come across that? Did you guys think about, you know, changing that? Because cameras can have a very limited range, you know, and they can move with the, you know, whoever's moving. Did you guys think about making sure that the cameras can be moved?
Yeah, they do.
So in drafting this bill, we reviewed the laws from other states with regard to the requirements for cameras. I will say this is the only example we found of a common area requirement. All of the other states, there are camera requirements if the family wants a camera in the room. And certainly some states have that requirement that the camera be in full view, conspicuous, and mounted so that it can't move around. But here, where what we're looking to do is look down a hallway as much as possible, use a fisheye lens to catch the whole room, catch the entrances. We're less concerned about those requirements. We just want to make sure that we're capturing as much of what's happening at any given time as possible.
Okay, thank you.
Next, I have Delegate Chisholm.
Thank you, Madam Chair. Thank you for bringing the bill. I truly appreciate the intent of the bill. I did find it somewhat intriguing that the SEIU and the bigger labor unions are against the bill. I would think that they would want to be, you know, cleared of any doubt. So my question is, do you think they're complicit in the problem? Obviously, there's an issue, and it's sad. In fact, Zach gave several examples. I don't know if they were in nursing homes or assisted living, but if there are workers, do we feel like that they're not policing themselves and that they're actually, obviously, they're betrayer of a lot of this, but I doubt that it's done in a void. Do we feel like they are, at the end of the day, the ones most responsible for this?
Just for clarification, they being whom?
The AFL
Oh, the labor organization itself?
Yeah.
No, we're not going to speak to the complicity, motives, intent, concerns. They're going to have an opportunity to testify. Certainly ask them about that. Look, like in so many professions, the vast majority of providers, and this is true whether it's in law enforcement, medicine, as a lawyer, I'd like to think law as well, that we're upstanding folks and doing the right job for the right reason every day. In every profession, there are bad actors, and this bill is to really make sure that we're holding accountable those bad actors in that particular line of work. But that is no suggestion that that's what characterizes the men and women who are doing that work every day.
Right, and the blessing and the curse of this committee is you get to testify and then you go back and then somebody says something and you don't get the response. So I figured I'd let you respond at least while you're up here because, as you said, they're going to come testify and at least you've got a chance to state what your belief is. Thank you, Madam Chair.
You're welcome. Delegate Hill, followed by Taveras, followed by Whitehall.
Thank you, Madam Chair, and thank you, Mr. Attorney General, for the bill. Certainly, abuse is a problem that we should not tolerate at any level, and abuse of the elderly and those who are least or most vulnerable, least able to protect themselves is particularly egregious. We heard testimony in this committee on a bill a couple of weeks ago about the inspections that haven't been going on and how far behind we are in inspections. Last year, we passed legislation giving the AG's office injunctive relief over these facilities so that you can tell them to stop. So my question is, because I'm very concerned about the privacy issue and concerned about the safety issue you're trying to address, is why is this your solution as opposed to we get a complaint, we get a subpoena, go to the owners, and tell them they're not to inform their employees, and we put cameras in so that we can catch if there's an employee who's doing the things that the family's accusing them of. Why is it continual surveillance at all times? Obviously, we're pressing to get the inspections done that ought to be done on a regular basis so that we can look for where there are problems and all that, but why are you not looking to simply go to the owners and say, under a subpoena, whatever, we need to put some things in here?
So that's certainly one approach. I think it's reactionary. I think it also is very likely to be met with, what are you talking about? Didn't happen in our facility. Show us. Well, we can't show you because you don't have the cameras to show you. Say, well, we heard from a particular patient or their family. Well, that patient always says this. I mean, there'll be excuse after excuse after excuse, potentially. So it's reactionary, and we don't think it gets after what we need. We're talking about video footage so that when we are seeing the signs of abuse that we have the experience of recognizing, but are limited in what we can put on to successfully prosecute because we don't have the evidence. This is going to help us bring this all the way to fruition. From the first encounter, applying our professional judgment and experience, putting together a case, recognizing the weakness of a case when someone has dementia or is nonverbal, and then now this gives us the tool to bring it to fruition.
And how big a problem is that this extraordinary tool, you feel, I mean, we're not doing it in other places where we live. We don't have it in necessarily every hotel's not required to do it. Every other public, this is a private space. It's a home to these people. So
I think there's a difference in a hotel, and I think there's even a difference in a hospital. One may say, hey, how come you don't have this in a hospital? And probably the big difference in the two settings is those are much more transient and temporary, and often, not always, but often someone's accompanied, certainly in a hospital, by family who's checking in, not always, but often. In a hotel, right, you're typically, although not always, but people are verbal and they're able to articulate their needs, their concerns, their fears, et cetera. So the populations and the experience in those settings are markedly different than in these long-term settings where often family members are there and they won't have a visit from a family member for weeks. And you hear the stories all the time, assisted living and nursing. And so they're really different settings.
Okay, thank you, Madam. Thank you,
Pleasure.
Mr.
Delegate Taveras, followed by Delegate White Holland.
Thank you, Madam Chair. Thank you for bringing, hold on, where are my glasses? Okay. All right. Thank you for bringing this bill forward. I am concerned that these are things that you're coming across. It's sad. I take a little bit of issue with saying the unions are complicit in this, as a lot of these letters highlight. Abuse and neglect is rooted in understaffing, lack of training, hiring, and retaining qualified caregivers. There are two issues that I think I'm seeing in this legislation is that these videos lack audio, right? And I speak from personal experience in that there's no address to the fact that patients themselves can be violent or abusive themselves, triggering a reaction. I have family members that they were just hell on wheels, working, dealing with them. So God bless whoever had to work with them. So how do you address that in this legislation?
Two things, and I don't mean to be glib at all, but there was no audio in the Rodney King video. You didn't need audio to see that someone was being violently abused. What I would submit is that in the video that we're talking about and what you'll see in the screenshots, and again, we can show you the videos, that these are clear signs of abuse, and there's no verbal exchange that could explain away what you will see on those videos. The other thing, kind of your second point, and I think, again, this is sort of maybe it ties together the two questions. Why would someone be opposed to it who is an employee in this facility? You're right. There are times when patients act out violently and do harm to themselves or to others. And this video could certainly exonerate or explain why it is that the caretaker, the employee, was not liable, was not irresponsible. So that's what I would offer to the 2 points that you've raised.
Thank you. So I have Delegate White Holland. I have to get on a meeting for one of the bills we have. Delegate Vice Chair Collison will continue. The committee's taking a break at 3:30 to deal with another meeting that some of us have to be in, and we'll be back at 3:50. So we're going to continue with this bill, finish it, take a break at 3:30, come back at 3:50, okay? Thank you very much. Delegate White Holland, Vice Chair Collison, all yours.
Thank you, Madam Chair, and thank you all for your testimony. I would like to kind of take us a little bit further upstream here, because again, when we are looking at videos, the incidents or the behaviors that you are monitoring will have occurred in the past, right? And of course, we all want to make sure that the abuse in these particular spaces or things that may be happening, that we can prevent these things. And so I was wondering if you could expound upon, because again, as Delegate Hill mentioned, there are outstanding inspections. And we know that if there's going to be additional efforts that will be needed to monitor and to watch and to take a look at some of these things, we know that that will be ongoing work that will be added to the existing load that exists. And so if it would be helpful, because I'm a public health person, so I like to think upstream, right, and how we can prevent things from going downhill. And so I think it is helpful if we look at things at a larger macro level here, and how can we take it a little further and making sure that we're creating a workplace and environment that would encourage positive, compassionate care, and not necessarily an environment where there's ongoing surveillance that could very well feel threatening with this ongoing surveillance and the like. And so it would just be helpful, and maybe it is outside of the scope of this bill, but just maybe at large, what does prevention look like in these particular spaces? And how is this particular solution contributing to that?
Sure. And I certainly commend this committee, because that's what you consider every 90-day session, right? How do we make that experience safe, quality, and care? And you know better than we do that there's so much that goes into that. There's training, it's the quality of the facilities. It is the frequency at which Office of Health Care Quality does its inspections, right? And just like the inspections, right? Knowing that you're subject to inspection is one sort of enforcement mechanism, right? And that's why we are often very concerned that OHCQ is not doing inspections, like who's watching, right? So this is kind of like that. This is one of the puzzle pieces in the many puzzle pieces that you work with every session to make that experience safer and better for the resident, for the care provider, et cetera. So we're not offering this as the solution, that upstream prevention. But we do believe that by enforcement and holding people accountable, and this is not unique to this industry, that contributes to ensuring that people are doing what they're supposed to do. So it's not the silver bullet. It's not the only thing that I know that you're looking at, and we would hope that you're looking at more. But we think this is important, because even when all those upstream prevention measures are put into place, there is going to be bad actors. There will be. There will be those who, regardless of the amount of training and supervision and oversight, and you see it in every profession. And when that happens, we need to be able to hold them accountable. And we're able to do that more effectively with the video footage.
Okay, all right. Thank you, Madam Chair. Thank you, Delegate. I have Delegate Rosenberg and then Delegate Johnson.
Have you had any discussions with the industry in an attempt to try and reach a compromise?
Yeah. Yep. Talk about those. Yeah.
Certainly, prior to introducing this bill, back when we were drafting it, we held stakeholder meetings to sort of sit down and work through what concerned the industry and how we might be able to accommodate that. And so the bill that we have before today is sort of a product of those initial discussions. And of course, we welcome the opportunity to further develop it through further discussion. But yes, we did, before we brought the bill, have at least initial conversations.
And to be clear, still disagreement, so we're not suggesting that this bill is that consensus bill, and that's why you'll see opposition to the bill.
Thank you.
Okay. Delegate Johnson.
Thank you, Madam Chair. In these cases of abuse, are they complaint-driven, and do you only use the video to collaborate or for evidence in those cases that you're investigating?
All of our cases come through referrals to the office. Now, that may be a family complaint, someone who just calls in because they're concerned about what they saw during a weekend visit. We also get mandatory reports that come in through the Developmental Disabilities Association from providers. We get complaints from direct service providers and healthcare professionals who perhaps see an individual during the day and see that they've got a broken bone, they've got a black eye they didn't have the day before, they have severe burns. We get reports from hospitals who are concerned when they see evidence of abuse. So we get our referrals from a lot of places. Most of the time the referral will say, there's a video. We've had cases where the video is shared on either social media or on WhatsApp between staff, and someone gets the video and is disturbed and reports it to us, so we know there's a video. Our investigations will always see if there's video. That's one of the first steps, because if there is, that's a real It's a real benefit, right? That gets us there quicker. But in a majority of the cases, the initial referral will reference the fact that there's video.
Thank you, Madam Chair. Thank you.
Delegate Hill. Is this a
Just a
second
quick
time?
question. When Delegate Rosenberg was asking, I also don't see anything before or in favor of or in opposition from like MACRA. And even though independent living, retired communities are not assisted living, CCRCs do have assisted living components. And the residents there often have friends who are in assisted living or loved ones or spouses that are there. They have concerns about the care. And I'm just curious, if you haven't, would you consider even reaching out to them to get their feedback? Because they're not the owners. They're the people who live near in good proximity, and would be interesting to see how they feel. And it may be that they're already living in many other cases with cameras in the common areas. I know some of the ones I visit, I see them in the hallways. I don't know how frequent that is. But I think for me, I think for many of the committee members, if we understand how, is this similar to what's already being done in similar situations, or is this really a big leap? And we're comparing it to our own home situations. And have you reached out to them at all as proxy representations for residents of assisted living and nursing homes?
Yeah, our stakeholder outreach was to those who would be impacted by the bill. Yeah, so that's who we reached out to.
All right. Thank you.
Okay. I don't see any other questions. I do have a question. And perhaps you'll be able to say what, in response to my question. I'm wondering, I mean, you've heard a couple of our colleagues say that OHCQ is severely deficit in its annual inspections of nursing homes. And to the extent that, I mean, I testified the other day that there's been one inspection of the 34 nursing homes in Montgomery County in the last year. And they're supposed to be annual. Under CMS rules, they're supposed to be annual. So I'm wondering, and one of the reasons in my conversations with the health department have been, they're tied up with complaints. And they've got to deal with the complaints first before they can do the surveys, the annual surveys. So I'm wondering, is there collaboration between your office and OHCQ to, I think, be a little more preventive of the kinds of issues that we're concerned about here, and be more responsive in some cases, since they have a backlog and you seem to be able to handle them more efficiently? So, or at least that's what we're seeking. So can you help me understand that relationship?
Absolutely. So we do work, the Medicaid Fraud and Vulnerable Victims Unit does work very closely with OHCQ. We're in the same space. And we are focused on abuse and neglect, but let me be clear, I think when we sort of envision abuse, we have this picture of like violent physical assaults, but it's a spectrum. And a facility that consistently understaffs, under-resources, or bleeds off money to the pockets of owners rather than reinvesting it in patient care will see the same outcomes as someone who's punched or kicked. We will see horrible bed sores, we'll see malnutrition, we will see physical injury all along that spectrum, but the cause is different. And so OHCQ is sort of on the systemic side. They're trying to in your words, go upstream and do some preventative, make sure that we're providing the level of care that will prevent those injuries. We do that too. It's sort of separate from what I've been talking about all day, which is direct criminal acts of physical abuse. But we also get lots of reports about these sort of systemic problems where someone got bed sores because no one turned them, or someone fell because they should have been being watched and they weren't. And what we do, and we get these reports from OHCQ, and that's often our first clue that something's wrong, but we monitor those complaints, we monitor those reports, and oftentimes we will go out to a facility and we have a bit of a different take, but we'll do an investigation and we use it's a fraud case. We basically say you're charging Medicaid for services you're not providing. But we have more recently, in the past 2 years, tried to use that legal mechanism to leverage what's called a corporate integrity agreement, where we bring in an outside monitor, sit with that facility for 3 to 5 years, and give them suggestions and guidance on how to do their job better. So we really work in parallel and in cooperation with OHCQ because we have the same end goal, which is to provide the best quality care that we can for our long-term care residents.
Thank you. Mr. Attorney General, did you want to say something else?
Yeah, thank you. And it was, there was a reference to blessings and curses of presenting bill testimony. And I know that this committee is really good at sort of identifying positions of opponents so that we can respond because we were not going to get another bite at the apple. Well, in this case, we were already in the Senate, so we do have a sense of the opposition. So there's just 2 points that I want to raise that you are going to hear that hasn't come up, I think, although the privacy has. It's an invasion of privacy. So this is why we are coming forward and saying common area. And then you're going to hear, well, wait a second, these are people's living spaces. No, that's why we're doing common area. And think about it. Cameras are so omnipresent in our society today. They're everywhere. And when you're in common areas, and you probably don't even notice it, you kind of look up and say, oh, you know, there's a camera right there. Right? So this is common area, right? The expectation of privacy is considerably lower. Yes, I get that this is a residential facility for these folks, but this is not their private area. So that's one point I wanted to hit home. The other one is if you put these cameras in, it's going to impact quality of care and recruitment. But then you'll also hear in that same testimony that, well, we don't really need it because there are a lot of nursing homes and assisted living facilities that do it anyway. Well, how is that? If it impacts quality of care and it impacts the ability to recruit, then why would somebody voluntarily put that in the common area of their assisted living facility or nursing home? So I would submit that, again, because in common areas, we as a society have less of an expectation of privacy, we see cameras everywhere, that you are going to attract quality healthcare providers. You are going, caregivers. And you are going to be able to deliver that quality of care. So I just wanted to take that opportunity to respond to what I think you may hear.
Thank you, Mr. Attorney General. Seeing no more lights, thank you very much for presenting this bill today. And I'm going to call an unfavorable panel, first with the folks who are present. So Dana Kaufman and Allison Siborowski.
Thank you, Madam Vice Chair and members of the committee. My name is Allison Siborowski. You pronounced it perfectly, Madam Vice Chair. Here today on behalf of Leading Age Maryland, and we respectfully request an unfavorable report on House Bill 576. We represent over 150 nonprofit aging services organizations across the state who provide healthcare, housing, and services to more than 20,000 older people each year. We do appreciate that the AG's office reached out to us and shared a draft of the bill last year. It was helpful to be able to see it in advance. Our concerns remain the same that we expressed to them at that time. We understand the intent behind the legislation, but truly the costs associated with implementing and maintaining the proposed video surveillance system in nursing homes and assisted living programs are significant and burdensome and cannot be absorbed by our member communities without additional resources. Let's take a look at the Medicaid reimbursement increase is proposed to only be 1%. Our member communities are facing inflation, increasing costs of food, electricity, wages, and benefits. Recent cost estimates to comply with this proposed requirement suggest that the initial cost of purchasing and installing the necessary equipment would range from about $50,000 to $200,000 per community, depending on the size and complexity of the installation. Also, the ongoing maintenance and storage costs would add between $40,000 and $80,000 to each community's annual budget. Furthermore, the 120-day recording is prohibitively expensive and exceeds industry standards, even for industries where surveillance is deemed crucial, such as police body cameras and marijuana dispensaries, which are pegged at 30 and 90 days respectively. For these reasons, we respectfully request an unfavorable report on House Bill 576. Thank you.
Thank you. Dana, you want to go next?
Yes. Thank you very much, Madam Vice Chair, members of the committee. For the record, Dana Kaufman. I'm here on behalf of Lifespan Network, and I am going to talk about two things that were brought up, and that is staffing and privacy. What is the difference with the staffing and the fact that some places do have cameras already? And it's really the intent of this bill. And the intent of this bill is punitive. It is for the sole purpose to detect abuse, neglect, and exploitation. That is the words that are written into the bill. It is not for assisting staff, but it is for prosecution. And the context of it is basically there is no trigger or a complaint that is filed. It is to turn them over to law enforcement or to a state agency upon their request. So our concern is when you look at a punitive nature, we are facing the worst staffing crisis right now in the state of all healthcare systems. We need staff, but it is very hard for us to help to recruit and maintain that staff. And some of that is because the state is failing the nursing homes itself. In order to work in a nursing home, you have to be a geriatric nursing assistant. But we have to let go of staff sometimes because the state is not able to administer the test that is needed. So we think if you're going to try to increase quality of care, we also need to be looking at our own state processes. As far as privacy, I'm going to respectfully disagree. Yes, cameras are everywhere right now. And if you go to Costco, you go to Walmart. But you go into a nursing home or assisted living, that is their home. Regardless of that resident's room, that entire building is their home where they can meet with each other, they can meet with their families. So I don't think you can say that just because cameras are everywhere, it is okay to put those everywhere in somebody's home. The second issue I'm going to talk about too is the fact that, when we first saw this draft, and I'm going to run out of time.
Can you say it in one more sentence?
When we first saw this, maybe not one, but I'll tell you quickly. When we first saw this draft, it was just for nursing homes, and it was 90 days. And then we had concerns. The second draft included then assisted livings, and it was 120 days. Assisted livings are very small providers. 74% are 9 beds and under. And 25% of those are owner occupied. So you're going to be asking owners to put cameras in their own houses. And we are very concerned that that could send a lot underground into being unlicensed. So for those and other reasons, we would respectfully ask for an unfavorable.
Thank you. Lorraine Ericat?
Thank you, Vice Chair and members of the committee for the opportunity to testify this afternoon. My name is Lorraine Arikat. I'm the Senior Policy Analyst with 1199 SEIU, largest healthcare workers union in the nation, representing over 10,000 healthcare workers across long-term care facilities and hospitals here in Maryland. We really appreciate the Attorney General's office's work on protecting vulnerable adults from abuse, patient neglect, and poor quality of care. 1199 SEIU respectfully opposes SB 465 because it fails to address the systemic and institutional causes for poor quality of care in our nursing homes. Our members know firsthand how nursing home management decisions to understaff facilities diminish patient quality care. While cameras might seem like a solution to prevent abuse or neglect, they don't necessarily guarantee better care. In addition, the legislation would authorize video recordings, which may lead to ambiguity as no audio would be captured. And the technology to detect abuse and carry out punitive measures does not hold nursing home owners and managers accountable to investing in direct care through hiring more staff, providing proper staff training and supervision, and some of the state investments we talked about as well with increased inspections. 1199 opposes this legislation as it violates direct care workers and residents' rights for privacy, especially for our residents with cognitive impairments like dementia. Constant surveillance could lead to feelings of discomfort, anxiety, or a loss of dignity. Lastly, installing and maintaining these cameras in all common areas requires a significant financial investment, We believe those funds could be better spent on improving staff to resident ratios, improving workforce retention through higher pay and benefits, or investing in training programs to enhance care quality. I also just want to point out states like New York, whose Attorney General's office has worked to address some of those systemic issues through addressing fraud, increasing ownership transparency, and increasing fiscal transparency so that we know how nursing homes spend their money. And lastly, we really urge the Attorney General's office to work with 1199 SEIU on solutions that can improve patient care, bolster jobs, and increase fiscal transparency. We were not part of the stakeholder group that was able to see this bill beforehand, so we really believe that for a multifaceted approach to address patient abuse, neglect, and exploitation, it must include the diverse care team at the table. Thank you so much.
Thank you. Questions for this panel, including Ms. Ericat. So I'll go with Delegate Kaiser, then Delegate Johnson, and Delegate Hutchinson.
Thank you, Madam Chair. My question's for Ms. Kaufman. A very targeted question that I have for you. I know you made the point about staffing being a problem, but at some point you said the videos are only for punitive nature and then they're going to send them to the police or to the Attorney General's office, whomever else. Who else should those videos go to? That's my only question. You seem to suggest the videos shouldn't go to them. If there were videos, who should they go to?
No, to clarify, the bill itself says that on request, the videos shall be sent to law enforcement and any state personnel in the ordinary course of their duty.
But you seem to suggest that that part was a bad idea, and I just want to understand just that component. Why is that? If there were videos, why would that be the wrong place for it to go?
I'm not saying that that would be the wrong place to go, but there's actually no trigger or due process. There's no complaint being looked at. I think it's going to be also very difficult. It says state personnel in the ordinary course of their duty. Who is that, and what is the ordinary course of their duty that is going to be requesting these videos just on whim when there is no reason for it? There's no complaint. There's no, trigger. So that was the point I was making.
Thank you.
Delegate Johnson.
Thank you, Madam Vice Chair, and thank you for coming to answer some questions. First of all, we do have some facilities that have cameras, so obviously it's not cost prohibitive. Second is, you talked about the staffing shortage, which we all know in healthcare we have staffing shortages. But should that use that as an excuse for someone to break the law and assault or abuse an individual, and them not have some type of recourse or video to go back and look at for that person to be prosecuted?
So I think for the videos, yes, there are assisted livings and nursing homes who have voluntarily put cameras in. It's hard for me to know if those cameras would be sufficient to comply with this bill, but a lot of them is for entrance and exit. But I think it's also the fact that the nursing homes and the assisted livings made that decision, and it was a budgeted decision, and there could be several different reasons, but I don't think that mandating it across the entire industry is the right direction to go to for increasing quality of care.
Okay, that's the video part. How about you use the understaffed, we don't have enough staffing.
What my concern is, and I had actually kind of forgotten that you asked that, so I apologize. It was a long question. What my concern is our recruitment and retention. We're fighting for staff with hospitals and all other healthcare settings. So why would a geriatric nursing assistant or a certified nursing assistant want to come to a nursing home or an assisted living as opposed to a hospital? I mean, it is very difficult work. And to be having 24/7 surveillance of their actions, we're just concerned that that could have a negative impact on our ability to staff.
Follow up, Madam Chair. So do you know if there are any cameras in any hospitals?
I do not know that.
Thank you. Thank you, Madam Chair.
Yes. Delegate Hutchinson.
Thank you, Madam Vice Chair. Ms. Kaufman, so you're here representing Lightbridge, so.
Lifespan.
Or Lifespan, sorry. If they suspect abuse in any of their facilities, what's their process to follow up?
So in both nursing homes and assisted living, there are regulations in place right now that requires any abuse, neglect, or financial exploitation to be immediately reported. Oh, I shouldn't say immediately, there's actually timeframes, but to be reported to, and it's a couple different agencies. It's OHCQ, local law enforcement, the state's ombudsman, and adult protective services. Failure to report that is actually will subject the individual for failing to report to financial penalties. And I think it's also important that, nursing homes, assisted livings are a state run program, but nursing homes are both federal and state. And the requirements on the federal line is that if it is an actual harm, you have to report that to those agencies, to the state survey agency, within 2 hours. If it is a suspicion but not actual harm, it's within 24 hours. And then the state survey agency is supposed to then investigate within 5 days. So I think going back to the fundamental issue here is what is the best way to increase quality. And to us, the best way to increase quality is to enforce the laws on the books. And that is to make sure that those surveys, both annual and complaint, are being done. I think I said this before, or maybe I said this in the Senate, but I've been representing this industry for 22 years. And the issues that we have now with the surveyors have never been the case. Before, nursing homes could mark on their calendar when they were getting their next survey. We need to get back to that, and that is how you increase quality of care. I do not think you can shift and think that this is going to be a solution. I think we have to get back to that fundamental. We need to survey, and we need to follow up with the complaint investigations when they are being received.
Thank you.
Delegate Hill.
Thank you. So I have a question, but I actually didn't hear the answer to Delegate Hutchinson's. He said, if I'm running or owning a facility and I have reason to be suspicious, what do I do to prove that my suspicions are warranted? What do I do to find out if the employees on the shift are doing something I don't want them to do? How do I investigate that? You talked about what I have to do to report it. He asked, how do they investigate?
We do. The nursing homes and assisted livings both have to have policies in place for investigations. I can't speak to exactly how they are done because I do believe that it's probably, it might vary between the nursing homes and the assisted living, but there are policies, which I'm sure it would require talking to who else is on duty, looking at files, things along those lines.
Okay, and for either of you, if I can get so my question is, I'm very concerned about the small home assisted living where you've got very vulnerable people, often who have little family support, often who are beholden to the people in that, 3 to 4 residents living in that facility. And if this is too intrusive, what suggestions do you have, other than inspections, for how we can better prevent the abuses that often take place, not often, that can occur there? Because again, what we're doing now is after the fact, right? It's a complaint because someone saw something. There is, the Attorney General suggesting that this is actually has a preventive deterrent effect. So in those places where it's 2 or 3 people a day taking care of these residents who have nowhere to go, nowhere to turn, what suggestions might either of you have? One of you, for what we can do better.
I have a lot of suggestions.
Okay.
On those. So, and I'm just, so you would be referring to the assisted livings. Mm-hmm. So again, Maryland has about 1,700, a little bit less than 1,700. For what you just said, 74% are 9 beds and under, 25% of those are 4 beds and under. Unfortunately, Maryland, many years ago, even before my time, which is hard to believe, took a view that it didn't matter if you were 2 beds or 100 beds, you were regulated the exact same way. I personally, and Lifespan also took this position that that is not the right view to have, that we should actually go back to a different licensing process where we take those smaller homes, they used to be called domiciliary care, and I think we need to take a look at that because a lot of those homes are the Medicaid waiver, they're also taking just SSI, and if we can take those away from the assisted living industry, call them domiciliary or whatever we else want to call them, and I think that there are other ways to provide greater resources to them, if it's training or case management services or something along those lines. But I do think that that would be a much better avenue to go down, and I would love to have those discussions rather than something along these lines of putting cameras, which I'm afraid could send them underground and become unlicensed, which is an issue that we've been fighting for years.
All right, thank you, Madam Chair.
Delegate Bandari?
Thank you, Madam Chair. Donna, you know that this committee heard during the COVID, after the COVID, the accountability and safety of the vulnerable individuals. And I do understand staffing, training, and better management are more effective solution than video surveillance, right? But the AG bill, when I read it, any abuse or neglect occurring due to poor staffing and management should be documented and investigated and addressed, right? So the bill intention should not be punishing the workers, and there is the accountability issue and safety of vulnerable individuals. In this light, you're talking about the survey. So do you have any kind of survey, how many residents they like this surveillance? And if you have any, could you share that? Because AG's bill is very serious, because I have heard a lot from my constituents that there is a negligence happening and we have to have a solution, and there should be a fine balance, and this committee has heard a lot about that issues.
Well, the survey that I'm referring to is the annual survey that is supposed to be done by the Office of Healthcare Quality. I don't have any surveys on, what the residents' opinion would be on this, but I do think, and I appreciate your comment on needing to increase quality. I just respectfully disagree that this is the right vehicle for that. I think there is other ways to go about that, which is, again, more of the enforcement and the compliance through the surveys, through the complaint investigations, through additional trainings, and I think we need to collaborate. The last point that I will make, again, is the last time I remember the state coming in and truly collaborating to increase quality that wasn't in a punitive nature was probably about 10 or 15 years ago when annual surveys were being done. There was actually another survey that was being done. And that survey didn't come in for deficiencies unless they saw something that, they couldn't ignore. But it really came in to talk to the administration and the staff about best practices and quality initiatives. And it was very well received by the nursing homes. I think that we should be doing more of that and really collaborating together.
Okay. Okay, Delegate Johnson for the second bite of the apple.
Thank you, Madam Chair. I don't do that second bite often, but this one kind of has me. I want to go back to, you mentioned the workforce again, and you used the hospitals as an example. So I did look it up, and yes, Maryland hospitals use security cameras in public areas and some patients' rooms, hallways, waiting rooms, cafeterias, to monitor, to prevent theft and violence, which we are talking about violence today. Parking lots, entrances, some patients' room, and intensive care rooms, emergency rooms, operating theaters, psychiatric wards, and special care units. So do you think there's any higher expectation of privacy in a common area of an assisted living than in a hospital?
I do. One, I don't think that we mandate the hospitals to have those cameras throughout the common area. I think that We've heard a lot about workplace violence in emergency departments and other areas. I think that is what that is trying to address. I also think that hospitals are much more of a public accommodation. The public is coming in and out of those hospitals on a daily basis, where in a nursing home and assisted living, that same entrance exit is not there. That is somebody's home. It is not really, it really doesn't fall under, in my opinion, the whole, public accommodation area. I think that is the big difference.
So you were talking about the workforce issue, though, about they would rather work at a hospital, and that would deter people from working at an assisted living facility or a nursing home. So do you think that's still a viable argument, knowing that hospitals do have cameras?
Yeah, I do, because one, I don't know, and I appreciate you looking at that, but I really can't comment on exactly where all of those cameras are. I mean, I don't know. I don't think that they are in resident rooms in hospitals. And I know that this bill does not go into resident rooms, but I still have a concern. The work is very different. I think that the work look, healthcare is hard. It's hard in any setting, and it is hard in a hospital, but it is also very hard in senior care. And I just do not, again, I'm going to say it, I do not believe that this bill is the right vehicle to be increasing quality of care. I think that there are other areas that we can look into that will not have this type of intrusiveness into these settings.
Thank you, Madam Chair. Thank you.
And Delegate Hutchinson is going to finish the apple.
Thank you, Madam Chair. I think this is the first time I've done this, but I think it's Allison, is that correct? I was just thinking, there's obviously a cost, whether my back of the napkin was, it's got to be within that range somewhere. Is it possible this could be passed through the Medicaid cost report and actually paid through Medicaid dollars?
I don't know. I mean, I think it would be great if the state was fully funding this. I think we'd be having a different conversation. But I don't think the state has an extra 60-some million this year and then 50 million every year after that to support it. But I think that if there was a mechanism for helping to fund this, because currently it's an unfunded mandate, that the conversation would be different.
Thank you.
And I wanted to ask Ms. Ericat, do you have any idea of what one of your members who works in a long-term care facility makes? One of the assistants, a geriatric nursing assistant. Do you have an idea of what the annual salary of that person is?
Yeah, it is about like $35,000.
$35,000 could buy a lot of staff with $66 million. So with that, there are no other questions. I would say we are completing the testimony on House Bill 576, and we are now taking a break for 20 minutes. It is 3:38. We are coming back at 4 o'clock. So please be back here at 4 o'clock. And those who are meeting with us, you know where you need to go.
with House Bill 869. Oh, you want to go, Okay. I was going to say, I'll go with you if you're ready. But I remember when I wanted, like, don't call me yet. Give me a few more. I get it. House Bill 869, which is Preserve Telehealth Access Act of 2025. And if those that are testifying, a Me Too is also very good and is welcome in this committee as well, especially when we have a lot of bill hearings, because I do not want to owe the committee a dinner. But if I have to buy the committee a dinner, I will gladly do so. Okay? And I will not be presenting the bill. I have an amazing fellow who is going to present the bill. And you can get started when you're ready.
Thank you, Madam Chair.
Please pull the microphone closer to you. Thank you.
Thank you, Madam Chair.
You're welcome.
Madam Chair, Vice Chair, honorable members of the committee, my name is Bolu Aderomo. I'm a Nigerian trained physician and a Master's in Public Health student and a Health Policy Fellow at the Johns Hopkins Health Policy Institute. And I'm happy to be here on behalf of Delegate Penya Melnick to advocate for a bill, House Bill 869, on Preserve Telehealth Access Act of 2025. This bill could transform how healthcare reaches every corner of Maryland. The Preserve Telehealth Access Act of 2025 isn't just another piece of legislation. It's about ensuring that no Marylander has to choose between their health and their circumstances. When we first passed the Preserve Telehealth Access Act in 2025, we were responding to an unprecedented crisis. What we didn't fully anticipate was how this emergency measure would become a lifeline for so many of our residents. The Maryland Healthcare Commission's 2024 report shows us that how vital telehealth has become. Behavioral health services delivered through telehealth grew from 15.5% in 2019 to an outstanding 59.5% in 2023 among private payers. These are not just numbers. They represent real people getting the healthcare they desperately need. Maryland has already established itself as a leader in telehealth innovation. According to the 2023 State Policy Agenda for Telehealth Innovation by the Reason Foundation, our state stands as one of the few that excels across multiple telehealth policy dimensions. We've successfully implemented modality-neutral policies, allowing healthcare to be initiated through any appropriate mode. We've broken down barriers to across state-line telehealth, and we've created frameworks supporting independent practice, placing us among the most progressive states for telehealth innovation. This bill is the next logical step in our journey. Think about Sarah, an elderly resident in Western Maryland, who can now speak with her doctor without making the 2-hour journey to Baltimore. Or Michael, a single father who can attend therapy sessions during his lunch break without taking time off work. These are the stories of telehealth's impact. Our neighboring states understand this reality. As of November 2024, 45 states and DC allow audio-only telehealth services, and 23 states have enacted permanent insurer parity laws. States like Connecticut have made their pandemic-era telehealth policies permanent, while Michigan has established both private payer coverage and payment parity. Maryland cannot afford to fall behind. This bill builds up upon our previous successes while ensuring sustainability. It will remove the 2025, It will remove the June 2025 sunset provision for audio-only telehealth coverage. It will ensure coverage for medically necessary somatic, dental, and behavioral health services. It will protect patient choice in how they receive care. It will maintain payment parity for telehealth services, and it will require the MHCC to provide a report on the advances in the area of telehealth, including involving modalities and changes in the cost of delivering services every 4 years. The MHCC's 2024 recommendation strongly supports these measures. Their study shows that telehealth has become a vital component of our healthcare landscape, promoting health equity and extending access to undeserved communities. Critics might argue about cost, but consider this. What is the cost of a missed appointment because someone couldn't find transportation? What's the price of delayed mental health care because someone couldn't take time off work? The Commission's findings show that telehealth isn't just about convenience, but it's about breaking down barriers to essential care. We stand at a crucial crossroads. If we do not act now, come June 2025, many Marylanders could lose access to healthcare services they've come to rely on. The audio-only option, which has been a lifeline for our elderly and those without reliable internet access, could disappear. The payment parity has made telehealth sustainable for providers could also vanish. I urge you to consider this bill and the real impact it has made on real lives. Think about the rural family who can now access specialist care without traveling hours, the working mother who can manage a chronic condition without missing work, or the veteran who can receive mental health support from the privacy of their home. The time to act is now. We cannot allow these essential healthcare services to sunset when we know how vital they've become. Let's show that Maryland remains committed to innovative, accessible healthcare for all its residents. I respectfully request a favorable report on House Bill 869. Thank you.
Thank you, Bolu, for your work. Excellent presentation. Who's next, please?
Go next. My name is...
Feel free to move the microphone closer to you.
Thank you so much. Madam Chair, thank you for the invitation to speak today. My name is Dr. Helen Hughes. I'm the Medical Director of Telemedicine at Johns Hopkins, where I'm also a practicing pediatrician. I'm providing strong support on behalf of Johns Hopkins for HB 869, Preserved Health Access Act. I'll just highlight a couple of brief points from my written testimony. One is that telemedicine's really been transformative at Johns Hopkins. We had 800 pre-COVID visits, and then in the past 5 years, we've had over 2.3 million. Telehealth still is about 12% of our outpatient care volume across a lot of specialties, including psychiatry, oncology, genetics, neurosciences. And then we still see disparities. We were able to publish on some of the video versus audio-only access and appreciate this group's leadership there. And in 2024, we see similar rates of audio-only use among Medicaid insured patient visits in comparison to commercially insured. So very much appreciate that part of the Preserved Health Access Act. We did want to just highlight briefly one point related to controlled substance prescribing in telehealth, which in our testimony in the American Telemedicine Association testimony highlights that Maryland has some regulations that are in conflict with the DEA's guidance. And so just urge anyone who's interested in that, we're happy to speak about that, but we would love to have Maryland have aligned guidance with the federal guidance, which would help with cancer patients, sickle cell patients, and hospice patients who need appropriate clinical care over telemedicine and prescriptions. So thank you so much for your attention to this important issue, and we urge a favorable report on HB 869.
Thank you. Who's next?
Sure. So good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Anthony Roggio. I'm an emergency medicine physician at University of Maryland School of Medicine and the medical director at the Center for Telehealth for University of Maryland Medical System. I've been an emergency doctor for the last 13 years. I've been involved in telehealth work for about 7, and I've been leading UMS's efforts to expand and improve telehealth services since the COVID pandemic. I'm here today in strong support of HB 869, which is critical to our work at University of Maryland and for the health of Marylanders. University has treated over 100,000 Marylanders in the last year using audio only and video visits, in no small part due to the previous versions of the Preserved Health Access Act. One patient in particular who shared her story with me, I think serves as a really good example of how important telehealth can be. This was a mother of 2 in Baltimore who works during the day and has typical visits to the doctor's office for general preventive medical care, but sometimes those were just not feasible for her to get to. Telehealth allowed her the flexibility to take time during her day or during her lunch hour to access primary care visits and obtain her medications for diabetes and hypertension. This is a visit she shared with me would otherwise have had to be delayed until she could take a sick day, which again wasn't always feasible for her, or she would come to the ER after work with her children in tow, of course. And it serves as an example, I think, for how many Marylanders, the choice is really not between just an in-person visit and a telehealth visit, but a telehealth visit versus maybe more expensive emergency or urgent care or delayed care or even no care at all. Many Marylanders face barriers to healthcare access, whether it's financial, transportation, insurance, or otherwise. And telehealth allows for the removal of these barriers. So it's no surprise that our data shows it's really increased access for marginalized populations, younger women, patients on Medicaid, and even Medicare populations. has also worked to integrate telehealth into multiple layers of our organization, using it to improve emergency department and hospital throughput, provide an alternative in cases of avoidable transfers and admissions, reduce healthcare costs, maintain flexibility during periods of short staffing, and provide patients a way to access high-quality inpatient and outpatient care regardless of their location or social circumstances. By making expanded telehealth coverage and reimbursement parity permanent, this bill would enable healthcare providers to continue to expand healthcare access for Marylanders and innovate to continue to improve patient outcomes and save resources. We urge a favorable report.
Thank you. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Nicole Grainer, and I'm here on behalf of the Community Behavioral Health Association of Maryland, representing 87 community-based providers who serve Maryland's most vulnerable residents. I'm here in strong support of House Bill 869. I will say me too, and I will also share a story that one of our provider members shared with me. The stories of a maternal grandmother raising her 7-year-old grandson who has experienced significant early childhood trauma due to his parents' struggles with addiction. Despite her own physical disabilities and financial challenges, she managed to bring him to in-person sessions until their only vehicle was stolen last year. Unable to afford another car and without the digital skills or resources for video telehealth, they turned to audio-only phone sessions. These weekly phone calls are their only link to therapy and support. Without audio-only telehealth, this family would have no access to the care that they desperately need. House Bill 869 ensures that telehealth remains accessible, effective, and equitable for Maryland's most vulnerable communities, and we respectfully urge a favorable report on House Bill 869. Thank you.
Thank you. Thank you for your work. Who's next, please?
Good afternoon, Madam Chair, Vice Chair Colson, and members of the Health and Government Operations Committee. My name is Damian Lang, and I am the State Government Relations Director for Shepherd Pratt. You have a copy of my written testimony, so I'll just touch on a couple points that I want to highlight for everyone. Telehealth has been a game changer for mental health care. In 2024, we provided over 200,000 telehealth services. Patients prefer telehealth, which is outcomes identical to in-person care when clinically appropriate. Despite efforts to return clients to in-person visits, telehealth remains our highest volume service. If required to shift entirely to in-person care, we estimate losing 40% of our patients, many of whom struggle with conditions like anxiety, PTSD, and severe depression. Removing telehealth flexibility would create unnecessary barriers to care. Today, 60% of outpatient appointments are virtual, serving over 10,000 patients statewide. Telehealth has helped thousands access care despite location, transportation, or other barriers. This has also eased the burden on emergency departments when beds are critically needed for acute care patients. Additionally, telehealth allows patients and families to maintain employment without missing work for in-person visits. Approximately 15% of our services are audio only, ensuring access for those without video technology, which is especially critical for historically marginalized communities, Medicaid recipients, and the homeless, and those in crisis. Many clients have phones but lack video access. Without audio services, they would lose mental health care treatment. And for these reasons, Shepherd Pratt urges a favorable report on HB 869. Thank you.
All right. Thank you.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Jake Whitaker. On behalf of Maryland's hospitals and health systems, we're in strong support of House Bill 869. Out of respect for the committee's time, I'll just simply say me too, and I'm happy to answer any questions. Thank you.
The committee loves that. I'm going to open it up for questions from this panel. Excellent. Thank you very much. It was very clear. Good job. Next, we're going to go to a favorable with amendment panel, which is the League of Life Health Insurers of Maryland and the Rarigan Youth Network.
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers, favorable with amendment on House Bill 869. I'm basically going to say me too, but I don't like when people say me too and then do 2 minutes, so I'm not going to do that. But I do have an amendment request, so I have to sort of vocalize that. And because the technology is changing so quickly on telehealth and the systems that we are all adapting to, things have changed a lot in the last 4 years. They're going to change in the next 4 years. We respectfully request an amendment to have the MHCC submit a report every couple of years to keep up with the payment and the modalities that are happening. But otherwise, me too. Thank you.
Thank you very much. We appreciate that. You have many friends now. Go ahead, next, please. And to the next bill. Go ahead. Good afternoon.
Good afternoon.
Just don't let them hurry up there. There you
go. Okay, go ahead.
Good afternoon. Thank you so much, Madam Chairwoman and honorary committee members. So telehealth has been a game changer.
Can you give us your name?
Oh, my name is Ishan. I'm a part of the Rare Gen Youth Network as the head of advocacy and domestic policy. And telehealth has been a game changer since COVID, and especially for mental health patients, seniors, working families, and students as well. And so some amendments which I propose are like the audio-only coverage amendment, because like many low-income and elderly patients lack broadband access, and this amendment mandates insurance coverage for audio-only visits to prevent digital exclusion, and licensing reciprocity, which is like where Maryland faces like provider shortages. And this amendment allows out-of-state licensed providers to offer telehealth services, which expands access while maintaining quality standards. And like an equity fund where telehealth, because telehealth access is not democratized across the board. So like a fund would provide grants for broadband access, telehealth training, and device distribution in underserved areas. And yeah, that's it. Thank you.
But great ideas. I love it. You're thinking outside the box. Very good. Are there any questions for this panel? Vice Chair Collison.
Thank you, Madam Chair. Thank you, Matt. But I just, and the amendment sounds totally reasonable. I guess what I'd like is like a specific idea, as specific as you can be, since you probably don't have a crystal ball. Like, what are you thinking about how things might change? What would we be asking MHCC to look at?
Delegate Collison, that's, I think, the point of the amendment, is I don't have a crystal ball. And I don't know what is going to be the new technology and the way we access care in the next couple of years. And I don't think we need to have a consistent report on a year-to-year basis. But the modalities have changed a lot in the last 4 years, and I have no idea what it's going to look like in the next 4 or 5 years. And we'd like that particular agency to stay on top of the new technology that comes along to see if we have to readjust the statute at some point.
Okay, great. Thank you.
Any other questions? See none, thank you so much. We really appreciate you. Let's go to an info testimony, just to be balanced. Will you take us virtually, please? Thank you. And actually bring the others as well, the other virtual witnesses. David Sharp. Hi, David. How are you?
Hi, good afternoon, Chair Pena-Melnick. It's great to see you. I'm fine. Thank you for asking. In short, the Maryland Healthcare Commission supports HB 869. I would say me too, to keep it concise, but I would also like to add just a couple quick points. First, nearly 42 states have laws mandating audiovisual and audio-only telehealth coverage parity. Secondly, I would note that approximately 29 states require some form of telehealth payment parity for private payers. And the last key point I would note is about 14 states have enacted payment parity for audiovisual and audio-only telehealth. And lastly, if the committee chooses to adopt the amendment as stated, we have had some insight to this, and we don't have any concerns about that amendment. At this point, for reasons stated by the panelists that have been before you, we would respectively request a favorable report on HB 869. It's great to see everyone, and good afternoon, committee members.
Thank you. And you can do that report, that amendment requested by Matt with assistant resources, right?
Correct.
Okay, thank you so much. And thank you for being with us. Are there any questions for David? Okay, and I call him David because I know David for almost 18 years. But
Yes,
anyway, Mr.
exactly.
Sharp, thank you for being with us.
Oh, too formal.
Thank you. Let's move on to, let's see, Laura Garcia.
Good afternoon, members of the committee. My name is Laura Garcia, and thank you for the opportunity to share some of my experiences with audio-only telehealth as a primary care provider and chief medical officer at Healthcare for the Homeless in Baltimore. I've worked at HCH for the last decade and can attest that one of the only silver linings from the COVID pandemic was the expansion of telehealth services more broadly to the American population. I would like to advocate today for the permanent continuation of audio-only telehealth services, which is a small yet crucial subset of the broader telehealth landscape that is particularly vital for my patient population, those experiencing housing instability. The challenges faced by these individuals are myriad, complex, and daunting. Audio-only telehealth services can be a lifeline for these populations, ensuring they receive the medical attention they need despite barriers to accessing traditional healthcare settings. Food insecurity, lack of reliable transportation, unemployment, no childcare, and concern about personal safety results in many competing priorities and ultimately barriers to accessing care. This only underscores the importance of a flexible and inclusive approach to healthcare. My patients often do not have access to the internet or data services through their mobile phones, but they are able to maintain phone services. By offering audio-only telehealth services, we can provide care that accommodates these challenging circumstances. This approach not only helps address immediate health needs, but also builds trust and continuity of care within these vulnerable communities. Almost 100% of visits we complete via telehealth are audio only. It is important to note that I can accomplish a significant amount over the phone. And while this is not appropriate in all circumstances, there are many things that can be accomplished during an audio-only telehealth visit, such as managing diabetes, opiate use disorder, and ongoing therapy. These visits are not just phone calls and should not be considered as such. I would like to end by asking for a favorable report on HB 869 to continue audio-only telehealth as a critical tool in my toolbox to support the health and well-being of individuals who are already up against significant odds to lead a healthy life. Thank you.
Thank you so much for the work you do, because I know it's not easy. Thanks so much. Are there any questions for Ms. Laura Garcia? Thank you so much. Oh, sorry. Delegate Kaiser.
Thank you, Madam Chair. I appreciate it. Ms. Garcia, thank you for your testimony, and I obviously heard you mention audio only, and I know that that's the nature of the bill. Would you have preferred the video component if that was an option? I guess it's the first part of my question.
So as a provider, yes, I will always prefer a visual component, but what I can say is for my patients, their ability to access a visual component is challenged for many reasons. Not being able to actually have the data services on their phones to be able to use the visual component. Also, the technical ability, being able to kind of get through the process of getting a link, clicking the link, that can be challenging for many of our patients. And so while, yes, that would be preferable, and when we can do it, we support it, it is very rare that my patients have either the means or the ability to do it.
Gotcha, thank you. I just want to mention that in 2020, I did physical therapy. And so would have been impossible without a camera to have me watch the exercise and have the therapist watch me do the same exercise back. So thank you.
Yeah. Thank you. And thank you for that question, Delegate. Any other questions? All right, thank you so much. Have a wonderful evening. Have a blessed evening. Mr. Savage?
The Honorable Chair Penamilnik, Vice Chair Colson, and members of the HGO Committee. I am Dr. Pat Savage, a retired licensed psychologist in Maryland. Thank you for the opportunity to address you today. It is good to see you again. I am testifying in strong support of HB 869 on behalf of more than 1,000 members of the Maryland Psychological Association. As others have said, telehealth is a game changer. Why support audio-only care? My colleagues and I have treated many patients who are elderly, technologically challenged, bedridden, institutionalized, people who suffer from neurological disorders or physical challenges, and people in crisis that can make navigating virtual technology at best challenging, if not impossible. Many lack internet resources, making access to virtual care impossible, yet they very often can access care through a phone. Some can only create the privacy required for the provision of behavioral health services when they utilize a phone. Including audio-only technology as a tool that can be utilized to deliver behavioral health care provides greater access to care that is vital to many's mental health. Why support equality of payment? Behavioral health care in general is already inadequately reimbursed. An hour of time counseling a person is an hour of time whether the patient is seen in person, virtually, or spoken to by phone. Behavioral health care is reimbursed by the amount of time spent with a person, not by the technology utilized to deliver the care. Disincentivizing providers through lower rates to provide either audio-only or virtual health care services will ultimately mean that some of our most vulnerable and difficult-to-reach populations do not receive the care they need. Given the dearth of behavioral health providers, our patients need to be able to use the full array of technology to receive care at reasonable levels of reimbursement. This bill maintains the access to care that many already successfully rely upon to maintain their mental health. We would like to thank Delegates Penemelnik, Cullison, Kerr, and Rosenberg for sponsoring HB 869 and ask for a favorable report. Thank you again for this opportunity to speak to you today on behalf of psychologists and the patients they care for.
And thank you for being here with us. Do we have any questions for Dr. Savage? Delegate Rosenberg.
Well, that's a more brief statement as a co-sponsor, if I may, than a question. That is, this all began with a regulation before AELR to expand this care through the telephone. And there was resistance to it, but we moved forward. Then there was the pandemic, and here we are today. And that's how we got briefly to this point.
Thank you. And I know you're the chair of that committee, and we thank you for your work and your services.
Thank you.
Thank you very much. Delegate Riley.
Madam Chair, yes, this question probably should have went to the sponsor of the bill, but I'm pretty sure the doctor that just spoke could answer since you had talked about it. So the bill is basically, and I support audio telehealth, but everybody could just, so the bill is saying audio telehealth. So if it's a new patient and they're doing audio telehealth, is there any kind of requirement at all that they ever have to see the physician inpatient or at least on video, or is it just strictly all audio and will remain that way?
So the bill is for both audio and virtual.
Okay, but if they're just doing audio, do they have to do something virtual somewhere along the line, like once a year or?
That is up to the provider, right? And that relationship that provider has with the patient. But the bill allows for both at any time.
Okay, that answers my question. Thank you very much.
My pleasure. Thank you. Thank you for the question. Any other question? Delegate Taveras.
Thank you, Madam Chair. I'm just wondering, making sure that will this now allow insurance providers to cover the psychologist when they are providing? Because it is my understanding that that was an issue before, or at least I've just, in my encounters with therapists, they said that they didn't cover people when they didn't cover people.
Out of state, perhaps?
Yes, they couldn't treat somebody that over audio. They had to have video as well, and their insurance wouldn't cover them. They would be in violations of their insurance.
Right. Out of state, I believe out of state, there's an issue, and it has to do with the licensing, right? The person being licensed in the state of Maryland. But in Maryland, we cover it.
Okay, next year.
Yeah.
All right.
Yeah. And we can look further into it, but I believe that is the answer.
Yeah.
Thank you. Any other questions? Delegate Woods.
Yeah, just, is there anything put in place that helps us to get a gauge on a client who vocally sounds like they're okay, but maybe something in the affect says that they're not, and because you can't see them, you can't make that determination?
Again, that is this is another tool in the toolbox, right? Your provider has a relationship with you, and they can tell when you're well or not well, right? And you let them know. I would assume this doesn't change what a provider is supposed to do, right? It doesn't change how they are supposed to carry themselves professionally, right? It doesn't change anything at all, the standard of care. It's basically another tool for them to be able to talk to their patient by phone, to be able to also do a visit virtually if they want to, but it does not change that relationship or whether they will want to see the patient or not. I myself have used it, right? And my doctor has said, no, I want to come and see you, right? If I say I have this rash and she cannot see it, for example, virtually, she'll say, come in, Jocelyn, let me see you. And I believe that that's the same for any provider. It doesn't change the standard of care at all. It is not the only way a person sees them.
So
Can you please mute yourself, Dr. Savish? Thank you.
I think what I'm not talking about the standard of care, I'm talking about the client themselves, not being able to articulate.
The patient?
Yes. In other words, that client perhaps not being able to articulate it in such a way that, because you can't see them, that you don't understand the gravity of the situation perhaps that they're going through.
I think that, again, this is another tool in the toolbox. It's not the only way that the doctor will see the patient. And for the 4 years that this has been in place, the report shows that there has been no problems like that. I think that it's a little bit of common sense in that relationship that that patient has with a doctor, that they can, if they're talking to them, that they can say, I'm in pain, and the doctor says, where's the pain? Or I can't breathe, and the doctor will say, call 911 or go. I don't think that anything like that changes, unless I'm missing your question, but it's just another toolbox. It doesn't change whatever communication that provider had with that patient. They'll know what to ask and how to talk to that patient to be able to get that out, because it's a relationship that that patient has with that provider.
Okay.
We can keep talking about it, but it's really another tool for them to use it. And if the provider did not have didn't understand that patient before, I'm sure that provider is going to say, come in, let me see you. If that patient needs help and has someone that assists, I'm sure that provider will say, come in with, your aid. It doesn't change any of that. This is just a way to make it easier for people. And we started using it 4 years ago. The insurance companies have been paying for it. And it was only temporary because they wanted to make sure that doctors were not going to take advantage of it, right? That no one was going to abuse it. And they wanted to make sure that it worked. And the study by the commission shows that it has worked as well. But it's going to go to subcommittee, and you can continue to discuss it there and see what, what the provider community says. Okay? Delegate Chisholm, and then Bagnell.
This is going to be, isn't that so, from my opinion? So I think what it has done, and I love telehealth, I think what it's done is increased accessibility. We have a younger generation. We're trying to always get into primary care. We're trying to get them in front of doctors. It may not be for everybody, but it's a very intimidating thing for people to go to a doctor. And with today's busy life, and we have a younger generation that's coming up that is very comfortable and maybe more willing to share via video with a doctor what's going on in their life or whatever, and they don't have time to drive to a doctor's office and sit. Telehealth, you get to cut out a lot of that. You get to cut out a lot of the waiting in a waiting room to be called and feeling intimidated and uncomfortable. So I think telehealth has actually been an incredible asset to encourage people to go see their doctor and feel more comfortable in their own setting. And then, of course, like you alluded to, if there's something where a doctor feels like they need to come in and see them, they know what's going on and can encourage them to come in. And it takes a lot of that fear out, I think, for a lot of patients. You talk to youth today, a lot of them haven't been to the doctor since their mom forced them to, when they were really young. So that's kind of my feeling on telehealth. I think it's been an incredible tool for a lot of the providers. And I do believe that it's probably increased access for a lot of people that may not have ever taken advantage of it before.
Yes, and I just got a text that says that health occupations law requires providers to bring in the person in person if they feel that they need to. So that is in law already as well. Let me allow the other witnesses, and then we'll go to the next questions. Okay, Ms. Metzger.
Madam Chair and members of the committee, thank you very much for having me today. I am an orthopedic and pelvic floor physical therapist who's been providing telehealth services for the past 4 years. In this time, I have grown from being fearful of this technology to embracing a brand new skill set and knowing that it is an essential part of healthcare. Offering telehealth changed my view of the service that I'm able to provide and has dramatically increased the number of patients that I am able to help. Patients who can access care get better, and those who cannot, frankly, do not get better. HB 869 will allow providers to continue to provide access to patients who are unable to come into the office and ensure that the reimbursement will allow us to be able to do that. Patients such as a stay-at-home mom who is suffering from back pain and urinary incontinence, but whose partner has returned to work and she is unable to come to the office because she has to load all of those children up. And so she's suffering and she's not able to take as good a care of her children. We can reach her at nap time so she's able to access care. I had a patient who was a military veteran who had been dealing with near constant severe testicular pain, who had a number of tests and scans and was not able to find a resolution. He called one day to say he would be late to his appointment that was in the afternoon, and we realized that he was driving almost 3 hours to access a pelvic floor physical therapist. After speaking with him, we agreed to try a telehealth appointment, and after 4 weeks of appointments at 1 visit per week, his pain was gone. We also are able to reach people who are not able to leave their home for quality of life concerns such as bowel or bladder incontinence, who might be isolated from their support system and embarrassed to go to the doctor. All of these patients deserve to be able to access healthcare with dignity and respect, and continuing to provide healthcare services will allow these individuals to seek and have access to the care that might seem like it is out of reach. I strongly support this bill, and please consider this testimony. Thank you very much.
Welcome. And I would like you to take Delegate Wood's question, since you are a provider, right?
Yes.
And try to answer it.
Can you
Ms.
repeat the
Fogel.
question, please?
Oh, let me just go to the next witness and we'll come back to you. Ms. Fogel.
Okay.
You're welcome.
Hi, Madam Chair, Madam Vice Chair, and committee members. So I'm going to keep this very brief. I'm Christy Fogel. I'm a physician assistant clinician leader with LifeBridge Health. I'm testifying on behalf of LifeBridge. You have our written testimony, which is in strong support of this bill. So I'll just say a few key things. Continuing audio-only and parity reimbursement is essential to allow predictability and further adoption of technology as healthcare delivery continues to change over time. We would also recommend the committee consider revising current Maryland law related to behavioral health services to align with any federal guidance on flexibilities allowing for use of telehealth. We have found significant improvements in adherence and reduction of missed appointments in caring for patients needing behavioral health services. So thank you for this hearing. We do urge a favorable report, and I'm also a provider. I'm happy to answer any provider-specific questions. I actually oversee a team of clinical telehealth providers at LifeBridge.
Thank you so much. So Delegate Woods, do you want to try the question on a provider?
So the question I was asking was, are there any safeguards put in place whereby you can gauge the affect of that client to determine whether what they're articulating to you and the gravity of their condition kind of match?
Who would like to answer that? Go ahead.
I can provide a physical therapy perspective. So I believe that we are currently required to have audio and visual synchronous connection with the client. So I have not done audio only personally, but I can see how that would be really valuable for other providers. But if I am able to see that they are not presenting like I would hope that they would, or if they are something that I would really truly need to see in person, then I have always asked them to come in person or ask them to see their physician in person as soon as they possibly could.
Okay, Ms. Fogel, would you like to try it?
Yeah, so I would also say, so this is part of the training of each individual provider, and Madam Chair is exactly right when she says this is just sort of a tool in the toolbox. My team in particular, we're all post-acute care PAs, so we all worked in the emergency department prior to this, and now we're dealing with post-acute care patients from the hospital, and I purposely hired emergency trained providers for this telehealth program so that I knew that they would be able to assess these patients. And a lot of times with post-acute patients, sometimes they come home from the hospital and they're feeling great. Sometimes they need to go back, unfortunately, because their clinical condition worsens. So it is incumbent upon that provider seeing them on telehealth or hearing them to ask the right questions and get them back to the right place. So if we have to call 911, we're calling 911. If we're getting the emergency department, calling the charge nurse in the emergency department saying, hey, I'm sending in a telehealth patient, we're going to do that. And we do that. And so I would just say that, is there a policy in place or is there some sort of thing that makes this happen? No, it's more incumbent upon the provider and the clinical team to make these decisions. And we are very, I guess in medical terms, conservative about this. If we feel a patient is unable to be really evaluated via telehealth or we're concerned, we're very quickly sending them into urgent care, primary care, or the emergency department.
So follow up, Madam Chair. So what I heard you say, I think what I heard you say, which is a part answer to the question, was that there are some people who are specifically trained, and I'm assuming that's not everybody, but there are some people who are specifically trained to know the difference between what's being said and the affect. Is that correct?
Yeah, I mean, this is a new space. There are some new programs that are coming out that are training people to assess via telehealth. My old physician assistant program has a telehealth class now, teaching providers how to assess via telehealth. But I will say as a blanket statement, if you are board certified to be a PA, nurse practitioner, physical therapist, physician, anyone who's seeing patients, part of that training is to be able to see and assess, right? If my mom calls me and asks me, hey, here's the symptoms I'm experiencing, what do you think I should do? I'm trained as a PA to be able to say, Mom, you really need to go to the ER. I can't look at you or hear you over the phone and do a full assessment. I need you to go into the ER so they can give a full assessment. So this is something that we've done way before telehealth was ever a thing. Providers were always getting phone calls from family, friends, or dealing with this in, primary care, urgent care. Patients call in and they say, what do you think, doc, based on my symptoms? And it's, part of our job to be able to assess and say, I can tell you what I think, or I'm hearing enough to say that you really need to go in and get a full evaluation. That's part of all of our training.
Can I add to that, Delegate Hill?
I usually don't, but I'm going to so that, because I know Delegate Wood had the question and I really value, the questions in this committee. So go ahead.
I think what I wanted to say really quickly is the whole issue of our audio-only care. Audio-only care is actually way older than video virtual care. And the reason I say that is I'm probably one of the older people on this panel, at least it looks that way to me. And way back when I first was a volunteer for the Mental Health Association of Montgomery County, I volunteered for their crisis intervention hotline. And we were often dealing with highly emotionally charged individuals, suicide individuals, individuals threatening harm to other people. And so we went through an extensive training program, even as para-volunteers at that point, in order to know what questions to ask, when to get help, when to pull in a consulting team to help us make sure we provided the best possible care to the individual on the phone, always making referrals out. I would also just add to that, because of having had SIPAC passed a number of years ago, we're required now to take courses in managing patient care through telehealth on, I believe it's an every other year basis that you have to be recertified for SIPAC. And even in our own ethics at this point, we're required to make sure we get adequate training to be able to, if we don't already have those skills, address some of the kinds of concerns you were talking about in terms of being able to ask the right questions, hear the right tone of voice, et cetera, even though we may not be able to see the person. Seeing is always better. I think everybody would agree to that, but there are lots of circumstances where it's literally impossible. So I hope that helps.
All right, so are there any other questions? Seeing none, thank you so much, and thank you for your patience, and everyone else that's waiting, okay? We have 2 more bills as we took these questions. We do have Donna Kaufman, Daniel Shattuck, and Robin Elliott left on this bill. Anyone else left on this bill that has not been called? All right, if you can come up, please. Thank you.
Madam Chair, Madam Vice Chair, members of the committee, for the record, Dana Kaufman, here on behalf of MedChi and several other healthcare entities. I want to say me too, and that's all.
Thank you.
I'm still a little
Next,
tired
please.
from the last bill.
Thank you. You're making up from the last one, right? Go ahead.
100%.
All right. Good afternoon, Robin Elliott, here in support of this bill. I'm just going to list out the clients who are supporting. So just to share that it's a broad range. We have the nurse midwives, the school nurses, school-based health centers, federally qualified health centers, a movable feast, which is a medically tailored meals provider, the Maryland Dental Action Coalition, and the Coordinating Center. Would very much appreciate your support of this bill. Thank you.
Madam Chair, members of the committee, Dan Shattuck here on behalf of the Maryland Academy of Nutrition and Dietetics. They are in strong support of the bill. You've heard from some of our other clients today, and me too.
Any questions for the panel? Seeing none, thank you very much. And this concludes the real hearing on House Bill 869. Next, we're going to go with Delegate Collison's bill, which is House Bill 659, Health Insurance Utilization Review Exemption for Participation in Value-Based Care Arrangement. Are there any witnesses for this bill here?
Yes.
If you can come up, please, to the, and Delegate Collison, Vice Chair Collison will do her presentation, and then she will go ahead and do the remaining bill. I have a meeting with the judiciary on the hospital bed issue, and I have to go upstairs to the speaker's office, okay? No disrespect meant to everyone. I'm just trying to be in 2 places at once, and it can be a little challenging.
And we haven't figured out how to clone her yet, so. Thank you all. We will have now House Bill 659, which is Health Insurance Utilization Review Exemption for Participation in Value-Based Care Arrangements. So we've heard about appeals and grievances and denials a lot this afternoon. I think utilization review, utilization management are probably some of the most hated words in modern medicine. We think that when we go to the doctor and the doctor diagnoses our condition, the doctor uses their best knowledge and experience to come up with an appropriate treatment. But under our system, under our healthcare system, that doctor, in many cases, must go to the insurance carrier, otherwise known as the payer, and say, this is the treatment I would like to prescribe. Is it approved? It is not. Is it not approved? If it's approved, all is good. If it's not, we go through a denial and then perhaps that grievance and appeal situation. Responding to denials and appeals is extremely tedious. I think we heard Dana speak earlier about the time, or was one of the witnesses about the time and administrative costs that doctors or practitioners may encounter because of that. And because of the prior to this year, starting January 1st, the conditions and restrictions and requirements around pre-authorization were fairly loose. When we passed the bill last year that sort of looked at prior authorization and reauthorization, we made some good progress in the process, but we didn't we didn't eliminate the need for prior authorization. We did in the case of reauthorization for some very specific drugs. So, but we hope that this will make some improvements, at least speed up the process and give people more information. But the process right now is really a check and balance on the practitioner. And it's not necessarily a welcomed check and balance. And it, but it is the responsibility ultimately of the payer to support the best patient outcomes. And I want to be clear, that's what I said first, the best patient outcomes while maintaining the solvency of the carrier for its members. So it has a place in our system. Then in 2022, we passed another bill which reflects a whole new relationship between a carrier and a practitioner. It's called value-based care. And this is kind of a national movement away from fee-for-service. Fee-for-service is based on the number of patients the practitioner sees, and the fact that there's some service delivered. In providers who are engaged in value-based partnerships, their success and financial incentives rely completely on the patient's outcomes and health, not just the fact that they received a medical service. Providers in value-based partnerships are empowered to address their patients' care needs holistically, focusing on coordinated care that proactively identifies gaps in treatment and social risk factors. These are the core elements to a healthy life, but they're repeatedly overlooked in a fee-for-service relationship where the economic incentives are not tied to the outcomes. So the framework of value-based care encourages practitioners to address health equity, social determinants of health, and improve the patient experience. But it's a relatively new concept. It's been around for a little while, but it's relatively new. Our law that we passed in 22 says that these value-based arrangements are completely voluntary, and practitioners are protected if they choose not to participate. It contains numerous patient and provider protections that are not necessarily in other federal programs and laws or private contracts in other states. What these two-sided arrangements do, there's a requirement that there's in our law, a requirement that a bonus or two-sided incentive arrangement must promote health equity, improvement of health outcomes. There's a requirement that these arrangements are voluntary, that there's an opportunity for an audit by an independent third party, and it protects the providers by setting a maximum downside risk that providers can agree to in any arrangement. In speaking with a carrier here in Maryland who is heavily invested in value-based care relationships, I learned that over 100,000 of their members are now being covered by practitioners who are engaged in these. And they are showing great promise in patient outcomes, consumer satisfaction, and affordability. So I started thinking, the utilization review process and value-based care models share the same goals: good health outcomes while being financially responsible. If that's the case, why not let these practitioners who have signed onto value-based contracts be exempted from the traditional utilization review management? A contract where they're not paid on the number of patients that they see, but how well their patients do. And they do have to agree to a certain amount of financial risk. Their payment is based on the goals that they have set mutually with the carrier. The practitioners have skin in the game. Many other states allow for value-based contracts, but we could only find one, and that's Arkansas, that sort of operates in this model, but it's different from what we're proposing. We could once again, Maryland could once again lead in good medical practice. there is a safeguard, right? Contracts are limited. If outcomes are not realized or the practitioners are not satisfied with the arrangement, the contracts could end. It's a novel concept. It's one that I believe merits discussion and exploration, and for that reason, I appreciate your consideration and perhaps a favorable report. I have here today Brian Wheeler from Care First, who is really the expert on these arrangements. So he's going to be able to answer your questions specifically, in addition to explain why he thinks value-based care is a good thing. But Dana and Dan, the two of you have been on many panels today, are going to speak to the practitioner's point of view on the bill. So either Dana or Dan go first. I'm going to let Brian do cleanup since you're going to be answering questions.
Thank you very much, Vice Chair Cullison, members of the committee. For the record, Dana Kaufman here on behalf of MedChi, the Maryland put this on. Maryland Academy of Family Physicians, the pediatricians, and then the Mid-Atlantic Association of Community Health Centers. We do support the bill. We appreciate the discussion and Delegate Cullison putting it in. I kind of look at this bill as, Utilization Review 3.0. Last year, we passed the legislation that went into effect January 1st to tighten the standards and provide more transparency. This year, you have bills before you to really take a look at the denial rates and ways that we can better protect and process those. And now you have this one, which is an innovative idea that we really hope would incentivize these two-sided risks. In 2022, 2023, when these bills were discussed, when this bill was discussed, it was a novel idea for Maryland. Physicians don't typically take risk. That is the responsibility of the insurance company. Physicians' responsibility is to treat the patients. But this is a novel idea for Maryland. The bill, as passed, did have many protections. But given the fact that the physicians and other healthcare practitioners would be taking risk on, it does seem like the next natural progression to exempt them from utilization review, something that does cost them both time and money in their practices. Other states have gone through what's called the gold standard, where if you have a certain number of, like a percentage of prior authorizations approved, let's say 90%, then you are exempted for the next year from prior authorization. That hasn't been readily accepted here, but this is a much narrower standard when we're looking at these two-sided risks. So we support the bill. We think it is a good idea to move these forward, and we would appreciate a favorable vote. Thank you.
Madam Chair, members of the committee, Dan Shattuck here from Brocato and Shattuck Consulting on behalf of a number of our clients, including the Physical Therapists Association. I want to echo really what you said, Delegate Cullison or Chair Cullison and Dana. We have in Maryland two-sided risk models, which are very carefully crafted. They're voluntary, which implies that those who are entering into those agreements are doing so with eyes wide open on what the goal is, what is the patient goal, what is the outcome to be achieved. Understanding that not just the money side of it, but you're really working on achieving equity and good outcomes. So given the carefully crafted nature of these models, it makes sense to remove some of these utilization barriers. Let's remove the step therapy and fail first and other administrative burdens, as Dana so clearly pointed out, that we can't just apply the standard way of doing business in these finely crafted models because it's a new concept and it needs to bear out and make sure that it's doing everything that's intended. So for that reason, we think this bill moves the model forward. It's keeping all the protections in place for both the patient and the provider. It's just opening and relieving some of that administrative burden. So thank you.
Brian?
Great. Madam Chair and distinguished members of this committee, I'm Brian Wheeler. I'm the Executive Vice President of Health Services at Care First Blue Cross Blue Shield. Care First is a not-for-profit company, healthcare company, whose mission is actually written into Maryland law, dedicating us to affordability, access, quality, and equity in healthcare. I've been at Care First for nearly 17 years because my personal values align with the mission of the company. I'm here to provide information today for this committee as you consider House Bill 659, which seeks to amend the landmark value-based care legislation passed by this body in the 2022 legislative session, as Delegate Collison mentioned. I appreciate the invitation from the Vice Chair today to talk about the Care First experience with value-based care over the past several years. It's great to be back with you on this topic. I was here quite a bit in 2022 when we worked on this together. We collaborated across the physicians, the Medical Society, the Hospital Association, and payers in partnership with the Health and Government Operations Committee to create a compromise legislation that could move value-based care forward in the state. The signing of that bill generated significant momentum between Care First and healthcare delivery partners in our network. I want to provide you with an update. In 2023, which was the first year following the passage, first calendar year following the passage of the legislation, Care First contracted with 12 accountable care organizations. These are generally health systems, so you're getting the primary care and specialty and hospital all under one umbrella called an accountable care organization. Also, we contracted with 7 large specialty practice organizations in what we call episode models. So these are specialists in orthopedics and gastroenterology and OBGYN who are managing episodes of care for members, and they're in contracts as well. These are some of the largest specialty providers in the state, as well as 2,245 primary care physicians, continuing a long-running primary care program that we've had for years. I'm talking about 1 million people who are available who are in these programs today. We haven't settled 24 yet, but I can report on the 23 results, and we've seen great progress. 11 of the 12 accountable care organizations perform better on affordability than the rest of the Care First book of business, and 100% improved quality measures in the period. Specialty practices all earned their incentives in 2023, and many primary care physicians demonstrated progress on quality and cost. Progress isn't easy in healthcare, and alignment is elusive, but much of the progress is attributable to the legislation that was passed by this group in 2022. Because of the compromise legislation in 2022 and limited provider risk of only 10%, we're concerned that HB 659 will place payers in a position of choosing between value-based care or retaining their ability to manage unnecessary utilization. We've only had 2 calendar years, and we're optimistic that 2024 is going to produce very positive results as well. The evolution of this model in terms of the downside risk, having two-sided risk that was greater than 10%, may provide an opportunity to expand this proposal in the future. And we look forward to working with all of the healthcare partners around the table to make care better in Maryland going forward. Thank you to Delegate Collison and the committee for the opportunity to provide this update today.
Thank you, Brian. Questions for this panel? Oh, my. Really? Oh, sorry. Delegate Taveras.
Hi, I don't know if this is the right audience or not. But I just want to make sure I have clarity in what this means. One of the testimonies speaks to including including medical necessity review, cost control mechanisms. No, sorry. They would like attribution methodologies to be prospective and to apply across a shared population rather than specific subgroups to facilitate creation of internal utilization management processes where appropriate. And I'm not really clear, at least from the hospital side, what that means. Is it like, don't take away my credit?
Okay, so they'll be able to explain what they're looking at for. Okay? All right, well, thank you all very much, and thanks for your patience in waiting today. I have 2 favorable with amendments. That's Matt Celentano and Jake Whitaker.
Madam Chair, members of the committee, still Matt Celentano, still here on behalf of the League of Life and Health Insurers and America's Health Insurance Plans, favorable with amendment on House Bill 859. I think we heard the sort of history of this bill. The carriers brought the sort of value-based care design to this General Assembly in 2022, and thank you all so much for passing it. But we knew what it was then, and I think it is still now. It was a foot in the door to start doing what a lot of states across the country are already doing, and Maryland was behind the curve on that front. When we were having those discussions, one of the overarching themes was if we enable value-based care, over the long term, we would be able to use it to address disparities, increase equity, improve healthcare outcomes, and more importantly in the financial side, it would reward and incentivize doctors to create better outcomes by utilizing services that lead to better health. With that being said, value-based care works. We know it works. It works across the country. When physicians have skin in the game, they're rewarded financially when they achieve better outcomes. When they don't, their reimbursements can suffer. So carriers are completely on board with the concept of this bill. We are happy to remove some of the utilization management tools that I'm very aware most of you hate, right? But only if it's a very true two-sided risk adjustment or a risk arrangement. It's currently just on the carrier. It's not truly two-sided. So our amendment, and when we asked to have time to be able to work on it, we love the concept of this bill. We needed time to amend this bill to have risk built into that relationship. And if we have risk built in that relationship, we are happy to move forward with this bill. So we ask for a favorable with amendment report on this bill. We're happy to continue to work on it, and we hope to get to a place where we have a favorable outcome. Thank you very, very much.
Thank you, Matt. Jake?
Thank you, Madam Vice Chair, members of the committee. Jake Whitaker on behalf of Maryland's Hospitals and Health Systems, here to support with an amendment. So obviously the hospital field is in very strong support of reviewing utilization management and reforming prior authorization. We just have some concerns and want to clarify some things related to the process, cost containment, and which populations are impacted by this legislation. So as the other panelists have mentioned, under these agreements, providers share in the savings if they deliver the care more efficiently than the benchmark set under these programs. But that said, the providers do share in the financial risks if we do exceed those financial benchmarks. So to answer Delegate Tavera's question, we're frankly just trying to work with the committee to kind of clarify how that risk is going to be shared amongst the providers and the payers. So with that, I humbly ask for a favorable report with amendments. Thank you.
Okay, thank you. Are there questions of this panel? All right, seeing none, thank you both very much. Thanks for waiting. And that concludes the hearing on House Bill 659, and we will go to the last bill of the day, Delegate Hill. And that is House Bill 820. It is health insurance, dreaded words, utilization review, use of artificial intelligence. And the Commissioner of Insurance is here.
Not real intelligence. Are there other folks coming up to the table, Madam Chair?
I have Dana Kaufman, Jake Whitaker.
Slide.
Yeah, that's it.
All right. Yeah. Where to begin? Well, good afternoon, colleagues. Good afternoon, Madam Chair, Madam Vice Chair, Chair. Terry Hill for the record, here to present House Bill 820, Health Insurance Utilization Review, Use of Artificial Intelligence. Delegate Tavares, you asked earlier this afternoon when we heard the Chair Pena Melnick's bills on utilization review and denials of service, how are we addressing the role of artificial intelligence? And I hope that you will find, and the rest of the committee will find, that House Bill 820 is a good start. So obviously, artificial intelligence and machine learning systems are no longer our future. They are our here and now. And as in many other areas, the application in healthcare comes with great potential and great risk. Our responsibility, of course, is to support the former and to mitigate the latter. Utilization management or prior authorization, service denials are a particularly sensitive application, which has seen significant increase in use in just the last 2 to 3 years. and application, but it has also had significant allegations of abuse, and it's also been grabbing much of our attention and the headlines. So a couple of examples. You all know that the recent murder of a insurance executive has been linked, possibly with overutilization of the denials of service. 2 days ago, it was announced that United Health Group settled for $20.25 million with the Department of Justice because of denials of service for urinary testing in emergency rooms. The system that they used then is supposedly not being used now, but that was a lot of people being told that their P-tests weren't going to be covered. And part of that settlement is to try and reimburse those people for the out-of-pocket expenses that they have incurred for service that should have been provided to them that was not. So those were a couple of examples. Also, in the last few months, we've seen reports from the American Medical Association and the Kaiser Family Foundation that looked at utilization reviews and denials of service and found that there has been, in some cases, depending on the insurer, and whether it's an MCO or an independent insurer, that we've seen almost a threefold increase in the number of denials of service, whether that's blood tests, lab tests, admissions, surgeries, that 80% of denials are reversed on appeal, but unfortunately, only about 10 to 11% of denials are ever appealed. And I can tell you that there are a lot of reasons why denials are not appealed. It's cumbersome. It usually requires that the provider find the extra time to fight for their patients, which many providers don't have time to do. It requires, as you heard testimony from the hospitals earlier, a great deal of additional staff to even go through the fight. And I assert that many healthcare providers know that, and insurers know that. And I know that earlier in my career, I heard from people who processed claims who said that it was easier to throw some of them in the trash can than to process them because you knew that the large percentage of them would never be reissued. And so that was a great way to save money. So recent reports have talked about how artificial intelligence systems, often outsourced to third parties, are playing a bigger and bigger role. And I'll get to that a little bit later. So HB 820, I'd like you to view as the third leg in this committee and in our chair's effort to better understand and address these troublesome trends, and specifically to address the role of artificial intelligence, AI, machine learning systems in accelerating this. You heard HB 995 earlier, which sets up a work group to study the rise in adverse decisions in healthcare, and HB 848, which is looking at adverse decisions and reporting and examination requirements. And what HB 820 does is it looks to gathering the data that we need to make the best decisions as to what types of guidance or guardrails we should be putting into place to make sure when these augmented intelligence systems are used as part of the process, that they're used in an ethical and responsible way. So whereas me being the hothead that some of you know me as, thought that the best way to address AI was to come in with some rules about the error rate, the algorithmic systems used, and the discriminatory error rates, and the harmful bias audits that we should be requiring healthcare systems to do on these systems, and we should report that back to the MIA, audit the results, et cetera, et cetera. Chair Pena Melnick, in her wisdom, and working with the people and other stakeholders, came up with a much simpler solution, and that's in 820. 820 simply requires that AI bias decisions that are being used in utilization review be based on a patient's medical history, their clinical needs, and supporting documentation from their providers, and avoid the one-size-fits-all determinations that often characterize the automated systems. It ensures that the data aggregation and AI tools comply with relevant healthcare access regulations and prohibits AI from making final medical determinations in place of human professionals properly trained to make those decisions. It also ensures that AI-driven decisions are subject to regular audits and reviews, that they comply with ethical standards, and that there are quarterly assessments as to the accuracy, reliability, and compliance with evolving healthcare standards. That's it. It is requiring through mechanisms that the MIA will develop that as part of their regular reporting, that the insurance companies tell us not just how many denials there were, how many clean claims they received, et cetera, but on those denials, were there automated systems used as part of the process? What was the role of those automated systems? And other kinds of very specific requirements. So this is really a reporting tool. And I hope that when we understand better how they're being used, then we'll be able to come back and come up with appropriate guidance and guardrails to best ensure that there is no exploitation and adverse effects to our Maryland policy holders. Okay, thank you.
Thank you, Delegate. Who would like to go?
I'm sorry. One more thing, if I may, because I may not get to say it later. I just want to read something to you. This is a ProPublica report, because I think it's important that everyone on this committee have an understanding of how significant these systems are. This report talks about the fact that many insurance systems use outsourced AI algorithmic systems, the most popular one being something called Evicore, E-V-I-C-O-R-E. And Evicore markets itself to insurance companies by promising a 3-to-1 return on investment. That is, for every dollar spent on Evicore, the insurer would pay up to $3 less on medical care and other costs. Okay? Evicore says it scrutinizes requests to make sure that procedures recommended by doctors are safe, necessary, and cost-effective. Okay? It doesn't say that the outcomes are improved, but that they're safe, cost-effective, and necessary. They claim that they're improving the quality of healthcare, the safety of healthcare, and by happy coincidence are also decreasing the amount of unnecessary cost. There's a great deal of evidence to the opposite, and one of the things that Evercare talks about is they can dial their algorithm up and down. This is what they brag about, based on how much savings the client wishes to receive. That's some scary business. That's some very scary business. And we need to understand how they're doing what they're doing so that we can come up with the appropriate ways of bringing them, reining them in to do their job, which is to prioritize the health of the patients. The National Association of Insurance Administrators has been looking at this issue for the past 2 or 3 years. And they actually, in a report in November, and then I'll be finishing up, called for 3 recommendations for regulators. 1, that AI systems have to use a standard of meaningful transparency. 2, that health plan ability for inappropriate or discriminatory utilization management has to be part of what we're requiring if we're allowing them to be used. 3, that human oversight by appropriately clinically trained persons be the ultimate decision maker, so that the AI system can speed up the process, but ultimately ought to be a person who denies whether you're going to have the surgery, whether you're going to be allowed to stay an extra night in the hospital. And I would add that we should also be looking to emphasize that patient outcomes should be the primary metric by which any healthcare algorithmic decision-making system is measured. Thank you.
Thank you. Who would like to go next?
I'm happy to go next.
Sure.
Madam Vice Chair, committee members, Marie Grant on behalf of the Maryland Insurance Administration. I'm going to keep my remarks really brief because Delegate Hill did such a fantastic job laying out the reasons why this bill is so important. It does really two things. First of all, it includes AI use in that adverse decisions reporting that we've been talking about this afternoon. And then furthermore, as Delegate Hill notes, it really gives us some better tools in terms of regulating the use of AI in that our carriers are using in the utilization management process. It is a step. I don't want to, I'm certainly under no illusions and look forward to working with Delegate Hill and with all of you in the future, but I think it's an important step. I think it moves the ball forward on some of those important concepts that the consumer representatives to the National Association of Insurance Commissioners called on our regulators to move forward this year in terms of what they were seeing in the report that they saw. And I think we will be offering a couple of technical edits for consideration, really just to make sure that our folks can enforce this up to the standards that they would like to see. But with that, look forward to working with you all and recommend a favorable report.
Dana, you want to go next?
Sure. Madam Vice Chair, members of the committee, my name again is Dana Kaufman. I'm here on behalf of MedChi and several other healthcare entities. We do strongly support House Bill 820. We believe that it partners very nicely with the bill that was passed last year. I think in the bill that passed last year, two of the main issues in that bill, or I guess that what we addressed, is making sure the standards were based on the medical society standards, as well as making sure that decisions, especially for denials, were based on the physician's determination. And we think that this bill, basically, it does not prohibit AI. It still allows for AI to be used as a resource and a tool, but it also emphasizes the need to make sure that the standards, again, are clinically based on the professional societies, but that the physician is the last determination, especially for a denial. So with that, I would urge a favorable vote. Thank you.
Thank you. Jake?
Thank you, Madam Vice Chair, members of the committee. Jake Whitaker on behalf of the Maryland Hospital Association here in strong support of this legislation. As I mentioned, the hospital field is in strong support of legislation reform coverage decisions. As you've seen, I think we've testified on 4 or 5 bills today related to this topic in strong support, especially in the use of AI and automated decision-making systems. We just want to ensure that patient access to care is determined fairly, consistency, and with proper oversight from a medical doctor. So with that, I will just simply say me too out of the consideration for the committee's time and request a favorable report. Thank you.
Okay, great, thank you. Questions for this panel? Okay. I have a question for the commissioner. In the way the bill is written, do you have the enforcement tools that you need?
I believe so. That's a great question, Madam Vice Chair. We do have some pretty broad enforcement tools throughout the insurance article that we can use. And so I don't know that we need more necessarily. I think the amendments that will offer me just be some clarity in language to make sure that there's a bar that we're measuring against.
Okay, great. Thank you. Okay. Oh. Okay, we'll go with Delegate Taveras.
All right, thank you. Thank you, Madam Chair. Dr. Hill, what constitutes as a professional? I think that in a lot of the language in some of the unfavorables, there was, oh, it's reviewed by a human. And you say a professional, I think that we want to make sure that there isn't a misrepresentation for what that is.
Thank you. And I think I only saw one unfavorable, and I think that there's, if depending on the conversation, there may be an amendment that we can offer that would be acceptable to everyone that would just clarify to them. They tried to, what I read in that unfavorable was they thought there was not a clear distinction between adverse decisions that were based on administrative things, like you didn't give me all the information, and those that are based on clinical. I think the article and the statute's already clear about that, but we can certainly have that conversation.
Thank you.
Delegate Bandari.
Thank you. Madam Chair, this is a very interesting bill. I would like to give you the example. Suppose a patient with a rare autoimmune disease, let's say for Maria, is prescribed a specialized treatment by her doctor, right? But the AI system used by her insurance provider denies coverage, citing a lack of sufficient data in its training model. Under House Bill, this bill, 820, how would regulators identify, number one, and address such algorithm bias in real time to ensure that Maria gets the care she needs, number one. And number two, additionally, since AI models operate as a black boxes, what mechanism in the bill prevent insurer from using that proprietary algorithm to avoid accountability and transparency in denial decisions?
Okay, so I think that, again, this is a reporting bill primarily.
Okay.
Right? So this bill is asking, what are your denials looking like? Which of those denials are based on algorithmic systems, and how do those systems function? I would love to be able to address what you're saying, but what we're doing is we're taking the first step in getting the information, and that will help guide what will probably be additional legislation next year that will come down with how we can look at that protective proprietary nature of it and set those ground rules. And again, it might be that for instance, we could say that your systems have to use data that's no more than 10 years old, and that you then have to add in the outcomes of the denials into the algorithm so that it's robust and it's an evolving statistical analysis. So there are all kinds of things that we can do with that, but it's frankly probably not fair until we know what systems we're talking about and how they're being used to devise the guide rails. Otherwise, we're sort of shooting in the dark.
That's fair. Thank you.
Thank you, Delegate. I had a chance to look at the licensed counselors and clinical counselors and licensed counselors. They had a recommendation that before a denial information was given to a patient, that it be given to the provider to assess before giving it to the patient or the patient's family.
Right.
Is that something that you'd consider?
I think it's already in there, but that's not if it's not clear, I think that's very consistent. So I saw that amendment, and that's not a problem. Put an amendment saying, again, the final decision maker has to be a human. If you're going to deny something, there has to be a human being who reviews the analysis of the AI system and compares it to the clinical data and says, makes sense to me. And that they're suggesting that be done, that it be a final denial before anybody is notified of it. And then that, if necessary, that appeals process could then be started.
Yeah,
And-
okay.
Right.
That works.
Madam
Commissioner?
Vice Chair, just because I want folks to be very clear too on current law, there has to be a person, a healthcare professional, at the end of the process in current law. And there's actually a clarification that, it's like belts and suspenders, you can't replace that role in current law, but that is current law today.
Okay, great. Thank you very much. Any other questions for the sponsors panel? Seeing none, thank you. We have one other witness for the day, and that is Matt Celentano. And he is favorable with amendment.
Oh, he's favorable.
Let's be clear, there was some opposition, it ain't me. Madam Chair, members of the HGO Committee, for the final time today, Matt Celentano here today on behalf of the League of Life and Health Insurers, favorable with amendment on House Bill 820. The League and the carrier members are supportive of House Bill 820 because it's further guidelines to ensure what is not happening now continues to not happen, which includes the fact that no carriers, zero, none, zilch, make an adverse decision with an artificial intelligence system. Contrary to misinformation we've heard from a bunch of healthcare stakeholders that makes me so angry every time I hear it, all denials that are a part of the system are always made by a human being. I want to repeat that. All denials are made by a human being. And in the law, if it's reviewed by a physician in the same specialty, no computer is making a denial. I'm going to say it 100 times more this session if I have to. The League members are currently operating under a bulletin issued by the Maryland Insurance Administration that came out in April 2024 that ensures all carriers comply with applicable insurance laws and regulations. This includes those laws that address unfair trade policies and unfair discrimination. That bulletin was based on years of work done at the National Association of Insurance Commissioners that developed a national model on AI regulatory structure that the carriers are now under. We take this very, very seriously. Just a level set, though, and because we're trying to all grapple with AI and the public policy involving it moving forward, and maybe to give this committee just a little more of an assurance, AI at its very core is just a tool. That tool and any other tool that carriers use is under strict regulatory the umbrella of the MIA. And like everything else in this world that's going towards automation, carriers are using automation in a way we think can be a force for good. I only have 20 seconds, but we know that there's a lot of scary things about AI out there. We do not utilize those scary things. In a lot of ways, we're using AI in the best possible way to create efficiencies, to speed up claims payments, to make sure that if there's a red flag in your medical record, you get a follow-up call to make sure you're getting better outcomes in your care. We have a very technical amendment, which is an omission of a couple of words from the California model in which this bill is based upon, but we asked for a favorable report.
Okay, thank you. See a few flashing lights, but I'm going to start on the left because I haven't paid much attention to them today. So Delegate Bagno.
Thank you, Madam Chair. I just wanted to ask Matt if there was anything that he didn't fit in that last 20 seconds that he wanted to say.
I very much appreciate it, Heather. Delegate Bagdal, but I think my 2 minutes and 6 seconds probably speaks for itself.
Okay, Delegate Lopez.
That was exactly my same question, just to provide a little bit of grace for the speed round.
Thank you very much.
Thank you. And Delegate Hill.
Thank you, Madam Chair. So, Matt, to give you the opportunity since you have the mic, can you explain what is the process generally for that leads to 80% of those denials being overturned?
Well, like any other request for a healthcare service, it is reviewed for some that require prior authorization and some that do not by folks within the carriers. And that final decision is reviewed by a physician in the same specialty before a decision is made. That is never made by an automated system. The denial is always made by a human that lets the physician know before it gets to the consumer, because the physician is the one making the request. So it doesn't go direct to the consumer, which I think was what was a part of the discussion before from Delegate Collison and I don't remember which specialty, I'm sorry.
Right. So you're saying the original denial is made by a human being at the end, and then we appeal it, presumably to a human being at the end. So why is it that 80% of the time that human being is overturned what is going on there?
Delegate Hill, that's not HB 820 in front of me. That's a different discussion. And I will say, from that to shift to that discussion of denials, we think that the numbers that we have been hearing and the data and statistics that have been coming out of this committee are very, very far off from what we see on the carrier side. There are denials in a lot of instances where it is basically bureaucratic red tape or the failure to be able to submit the right forms. Over the last couple of years, because you all know that we went through the entire redetermination process in the Medicaid program, there were folks that were no longer eligible for Medicaid and went into commercial plans, but they still had claims that were pending in the Medicaid system, but because they weren't beneficiaries, it was labeled a denial. The same kind of thing is happening with doctors have been double billing. You approve one, but you deny another one. The denial goes into the same bucket as the other buckets. So there are a lot of factors and a lot of nuance for us to dig down into. And that's why I appreciate the fact that House Bill 995, which we talked about earlier today, is something we're going to get to dig into on the interim, because some of the messaging that it was created by a tragedy in December has turned into, we feel like, an opportunity for a discussion that has not been balanced. And we're looking forward to being able to have that discussion over the interim.
All right, thank you. And Madam Chair, we understand there's another witness who did not get called up?
Yes, gentlemen, been sitting here all day. They
In the first row?
Oh, I'm sorry, I didn't have that on my list. So, are there any further questions for Matt? Okay, seeing none, then,
Thank you for bringing your bill, Delegate Hill.
thank you. Viraj Kamath? Rare Gen Youth Network again, thank you. Thank you, thank you for waiting.
Thank you. Chair, Vice, and esteemed members of the committee, thank you for the opportunity to testify today. My name is Viraj Kamath, and I'm the Vice President of Rare Gen Youth Network, which you've heard from. I'm here to testify in strong support of HB 0820, which ensures transparency and accountability in the use of artificial intelligence in health insurance utilization review. We support HB 0820 because AI-driven insurance decisions are harming patients, especially those with rare and chronic diseases. In our network, we represent 53 Maryland members living with rare diseases, many of whom depend on specialized treatments that are frequently subject to delayed approvals and wrongful denials due to AI-driven utilization reviews. These individuals are already battling complex medical conditions. They should not also have to battle an opaque algorithm deciding whether they get life-saving care. For example, one of our Maryland members, a teenager living with spinal muscular atrophy, was prescribed an essential gene therapy, but their insurance denied coverage not because the doctor ruled it unnecessary, but because an AI-driven system flagged it as not cost-effective, and it took months of appeals and physician intervention before the decision was reversed. In that time, their condition deteriorated. No patient should suffer because an AI system values cost over human life. I know this firsthand. I live with progressive familial intrahepatic cholestasis, a rare liver disease, and for years I fought through insurance denials for my medication or Sodiol. If my doctors had not intervened manually, I would have been left without treatment simply because an automated system failed to recognize the necessity of my care. The facts are clear. AI-based insurance denials disproportionately impact patients with rare diseases whose conditions often fall outside of standard algorithms. Patients already struggle with complex approval processes. Adding AI-driven denials without transparency only worsens the burden. And unchecked AI use in healthcare can reinforce bias, leading to systematic discriminations against those with rare, chronic, and high-cost conditions. HB 820 ensures that AI does not replace human judgment in critical healthcare decisions. Maryland has the opportunity to lead the nation in protecting patients from unregulated AI-driven insurance denials that puts lives at risk, and thus we strongly urge the committee to give HB 820 a favorable report. Thank you so much.
Thank you very much. All right.
Thank you.
Thank you. Thank you, number one, for being here, number two, for waiting all day, and number three, for your excellent remarks.
Thank you so much.
We are very grateful for your contribution to this conversation because, number one, the experience you're living, but also because you help us to frame what the policy we are making for the young people. So I really, truly, and the committee truly appreciates you all from being here today, for being here today. So thank you, and have a good rest of the evening.
Thank you for having us.
That concludes the hearing on House Bill 820 and the work before us today. If I could ask so just to remind folks that we are on the floor tomorrow at 11. We will be having a voting session after the floor, and then we have a briefing after our voting session. So plan your day accordingly. Other than that, have a wonderful evening. Thank you all today for your great questions and participation, and we'll see you in the morning.